Requesting all of you to kindly settle down in the banquet hall. We are absolutely ready to start today's conference. So, requesting all of you to kindly settle down. We are at the Valve and Structural Heart Update, organized by Forum of Advanced Cardiac Therapeutics. Can we have a big round of applause? Day-long conference here at the Talkutir New Town. We will be starting with the introduction as well as the lamp lighting of the ceremony. I would like to invite on stage Dr. Monutosh Paja sir to kindly come up on the dais for the inaugural and the lamp lighting, please. And big round of applause, everybody. I would like to invite on stage Dr. Srinivas Kumar. Big round of applause, everybody. Sir, kindly come up on the dais for the lamp lighting and the inauguration. I would like to invite Dr. Kunal Shorkar, sir. Kindly come up on the dais for the inauguration as well as the lamp lighting. I would like to invite Dr. Robin Chakraborty, sir. If you kindly come up on the stage for the inauguration as well as the lamp lighting. Also, I would like to invite Dr. Dilip Kumar, sir, if you kindly come up on the stage for the inauguration and the lamp lighting. Everybody, can we have a big round of applause? Indeed, a beautiful moment, and we are inaugurating with a beautiful moment. All our respected doctors doing the honors and special moment creating. We are inaugurating the Valve and the Structural Heart Update, organized by the Forum of Advanced Cardiac Therapeutics. We may be few on number, but can we give a louder round of applause, please, everybody?
सरस्वती भगवती निशेष जाड्यापहा नमो 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 सरस्वती मां नमो 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 सरस्वती मां.
All of you, sir, to please take your seat on the dais, everybody. Sir, please kindly take your seat on the dais. I would like to request Dr. Monutosh Paja, sir, to kindly say a few words and start this beautiful, beautiful conference. I will request Dr. Monutosh Paja, sir, to kindly share a few words and big round of applause, everybody.
Hello, good morning to all. It is my proud privilege to be present here because of dynamic Organization Secretary Dr. Dilip Kumar, who worked with me for 5 years and very excellent dynamic persons. So it's a beautiful venue of the conference. I think everybody is so much impressed because of the beautiful natural scenario in this Kopar. So that is a beautiful program and fantastic program. I believe whole day everybody enjoy such a program. Thank you very much indeed. I congratulate Dr. Dilip Kumar for organizing it.
Thank you so much, sir, for your valuable words. I would now like to request Dr. Srinivas Kumar, sir, to kindly share a few words for inauguration ceremony. Big round of applause, everybody.
Yeah, good morning, everyone. Welcome to this valve and structural heart update. Thank you, Dilip, for giving this opportunity to be here amongst all of you. And it's a pleasure to be in between seniors like Dr. Pancha, all of you here. Nice ambience, a very good atmosphere. So learning as well as this enjoyment in this should go side by side. As you all understand, there's a lot of interest in the country now with the structural heart therapy and the TAVR therapy being coming up in a big way. There's a lot of necessity also. Patients do survive longer, and not that we don't see these cases, probably they were going undetected. And many of the surgeons, I'm very appreciative of doctors, surgeons sitting here supporting this program, because combinedly as a heart team, both surgeons and cardiologists, IBHRE and all of us critical care specialists, together we should do what is right for the patient. That's what is truly reflecting about it, and this structural heart therapy is getting back the heart team concept. There's no more individual driven program. All of us should work together and do what is good for the patient, and there's a lot of training and education required, how to plan the therapy, how to execute this therapy safely to the needy patients. So we always keep the patient's interest in the top priority and do what is good for the patient. When the patient comes to surgeon, it's not TAVR. The patient comes to cardiologist, it's not TAVR. Finally, what is good for the patient, we have to combinedly take a heart team decision and do the best. And such sort of more and more programs would have hands-on training to the youngsters, and more of such things are required. Because Eastern India now, I think, also TAVR is big. And we really appreciate Dr. Lee for taking this initiative to come put this forum together. And nowadays, I know we do run CCDS program. Not easy to run conferences, but we should congratulate him for taking all these efforts. And thank you once again for the opportunity. And wish you all the best and happy learning in the coming months. Thank you.
Thank you so much, sir, for your valuable words. I would now like to invite Dr. Kunal Shorkar, sir, to kindly share your few words for our inauguration. Can we have a big round of applause, please?
Madam, thank you very much. I'm literally on my way to the airport. Now the question is see, surgeons and cardiologists over centuries have been viewed very comparable to two other very familiar species, and that is cats and dogs. And we've been at one another with regularity. But we, especially in the city, and I'm very happy to say in our hospital, we have a very congenial, collaborative ambience of working. And it has been a sheer pleasure to work not only with my colleagues in Medica, in Kolkata, but across the city, where I think we are managing to take the initial steps to develop intervention and advanced surgery in structural heart disease. And I think it is with this unified and synergistic approach that we will be successful in establishing high-end structural heart therapy in our part of our geography. Thank you very much, and extremely grateful for the opportunity. Thank you.
Thank you so much, sir, for your kind words. I would now like to invite Dr. Robin Chakraborty, sir, to please share a few words with us.
Thank you very much. Good morning to everybody, and respected people in the chair and the panel. It's a great occasion in the sense that the way I have seen cardiology and cardiac science, cardiovascular surgery over the years, it's remarkable. I distinctly remember my undergraduate days when the cardiologist, basically those doctors who are looking sophisticated, nicely dressed, and a very sophisticated stethoscope around the neck. That was the definition of a cardiologist. Then one fine morning, a cardiac surgeon decided to hand over a catheter to that gentleman, and he became a cardiac catheterization man. Then another morning, decided to hand over a balloon, then the stent, and of late, maybe sometimes 20 years ago, the same surgeon decided to hand over his valve to the cardiologist. You take charge of this. So that's how the intervention advanced. So what is happening perhaps, it is not the cardiologists are getting changed or cardiac surgeons are getting changed, Probably there is a merger between cardiologists and cardiac surgeons. There is a convergence I can clearly see, which is happening. So I'm sure that many of you are aware that in Europe, a lot of cardiac surgeons are nowadays in the Cath lab doing procedures, even doing TAVR. So during this point of convergence, we are here in the eastern part of India to have this conclave on structural heart disease. Thank you, Dilip, for organizing such a wonderful meeting. This is the initiation. This is the beginning of the beginning, certainly not the end of the beginning. And it will continue to go on. And I'm sure with all our supports and our patients' care and our cardiac surgeons' continuous input, this convergence will continue, and eventually the patients will be benefited. Patient care will evolve and take a new dimension. Thank you very much for a wonderful meeting.
Thank you so much, sir, for your kind words. I would now like to invite Dr. Dilip Kumar, the main organizer, the key person of the conference. Sir, if you share your words for the inauguration. Thank you so much.
So good morning and welcome you all. I am really overwhelmed with the kind of response I have got last 1 month from everyone from Eastern India to other parts of country. And someone told that structural heart conclave by any forum, cardiologist forum, will be successful only when your cardiac surgeons will come. And I'm so fortunate to have one of the most respected and accomplished cardiac surgeon with us in inauguration. And there are many, of them, our cardiac surgery colleagues will be gracing the occasion in scientific programs. So with this, I have teachers on dais and mentors on dais. And we have to respect the time, and that is all what we're going to do, showing sheer professionalism right from our conduct to our professional work. So we'll start on time without much ado. We'll invite the chairpersons and moderators of first session, and we'll start the scientific program. And I thank all the industry support which we have got, all the industry houses. Thanks again. Thank you so much.
Thank you so much, sir. We will move on to the first session. I will request Dr. Dilip Kumar to stay back on the stage for the coordinator of the first session. I will request Dr. Robin Chakraborty, Dr. Monotosh Paja sir to kindly stay back as a chairperson of the first session. Also, I would like to invite Dr. Bishwajit Mojumdar as chairperson of the first session, Dr. Kajol Ganguly, Dr. Uday Shankar Das as the chairperson of the first session. Can we have a big round of applause? I would also like to invite the discussants of the first session, Dr. P.C. Mondol, Dr. Ishita Mojumdar, Dr. Onup Banerjee, Dr. Tapobrata De, Dr. Kaushik Manna. Thank you so much. I would like to invite the first speaker of the session, TAVR in India, Promise and Deliverance, by Dr. Srinivas Kumar.
Thanks. Being the coordinator of the session, the job of the coordinators will be to invite and encourage more of discussions, more of scientific discussions, any questions which may be missed out, and points which are relevant to discussion. I think it has to be propped up. And there are some changes in the scientific schedule, timings and all, for the suiting the speakers, and that is to be forgiven. And then may I request Dr. Srinivas Kumar sir to start the session.
So, you know, Srinivas is dynamic interventional cardiologist in India, and he is the chairman of the FACTS, that means TCT Asia, and particularly he is devoted to interventional cardiologists for a long time, and particularly he is doing so many cases, and also the live workshop along with the TCT. And I congratulate Dr. Srinivas to organize the TCT meeting, and he is the first person who gave lectures today, the TAVI in India, Currents, Promises and Deliverance. Dr. Srinivas Kumar, please.
Yeah, thank you once again, Dr. Dilip and other organizers. And I'm also happy to open this conference as opening speaker and opening batsman. What Dilip asked me to speak is just briefly tell about what is the TAVR situation in India and how we are faring it, delivering it to the patient compared to what we are supposed to do. That is what is titled Promise and Deliverance. This slide brings best wishes from Apollo Group of Hospitals, where we are trying to collect the research data with TAVR registry and other things together so that we can come out with some positive research work. And I'm always proud to present my FACS professional service colleagues, about 26 of us. We work in multiple hospitals, but again with a single agenda of providing what is best to the patient. This has come very useful in this tough COVID times in the past, and also doing such high-end procedures like TAVR or chip procedures, things like that. I think I always make it a point to encourage youngsters to form teams, and that's how we can do good to the patient with good work-life balance. And what I would like to do in the coming 15 minutes is basically pay my respects and tributes to my masters and sites from where we learn TAVR, and briefly tell you about what is going on the TAVR scenario in the country regarding the numbers and which valves and things like that, and how the TAVR has expanded, and tell you briefly about the type of valves and probably what is an ideal valve. And many of the questions come with how the valves need to be selected, and then briefly take you through the evaluation procedure steps. This will be told in detail by subsequent speakers. So show you some case examples, one or two routine and one of the two high-risk things, and how is the TAVR therapy going to expand in future. And then I would announce and request all of you to join for the coming TCT India South Asia meeting. I'm always thankful, particularly to Dr. Sushil Kodali, my good friend, who is a valve therapy director in Columbia University, and he initially came to Apollo Hyderabad. We worked with him for a few months, and then that's how the therapy evolved. And other two big people you know here, they were the masters of CRF and TCT, Ajay Kirtane. All of them were instrumental in running the TCT India program in our hospital. This is Marty Leon and Sushil when they came, and we started the valve therapy program. And we were also fortunate to go to some centers to Europe and US, thanks to industry support again. I wanted to project Dr. Dilip also here. We had spent some good times in various spaces like Italy, Amsterdam, and then probably how aggressively the centers are doing both coronary and TAVR work we have learned. The heart clinic, I always like this concept of heart team, where surgeons and cardiologists sit together in the evening and decide what needs to be done, whether it's TAVR or mitral valve repair, replacement, things like that. It's a very good way to work. And very fortunate to go to, in younger days, it was a dream for us to just see Cleveland Clinic. Now a good friend, Samir, has become the chairman of that. We were fortunate to do some work there, and we learned the single femoral artery technique there. And the Cleveland University, just opposite it again, we have learned this cusp overlap technique, how to decrease these heart blocks happening. This is Atizani. He'll be doing live case in TCT again on July 27. Coming back to the topic, how we came down to the low risk is, all of you know, the Partner 3 trial. Surgery, though it is slightly better with less PVR and less LVVV, and TAVR was almost same like that, but TAVR performed better in decreasing mortality, strokes, hospitalization, kidney injury, bleeding, obviously many other advantages. So if you see the list is so big of the advantages of TAVR, so which therapy you think is better? Obviously people would say TAVR is better. So how this has happened is because the TAVR therapy emergence of it looks like almost all interventional cardiologists who are comfortable with stent. You take this balloon expandable valve, easy to implant, and that's how it has become equivalent to surgery, surgical bioprocesses without cutting. So what we promised to deliver to the patient in 2023 is we have to actually, this is further, initially after Partner 3, these percentages were there. It has further decreased now. So mortality is around 1%, strokes around 1%. But what is bothering to me is even in our day-to-day practice is vascular complications, which you all need to be careful. Though we promise it should be less than 5%, minor and major, if you include, they could be little more. Unless you become more comfortable with the closure techniques and all, you might have some vascular complications. And paravalvular leaks, I think, with cuff devices coming up, have decreased significantly. This is the promise we offer to these patients. But what we are delivering, I think mortality, strokes, we are there, but complications, decreasing it further, we need to work on. So in TAVR in 2023, we are not bothered whether the patient is doing poorly with surgery, or because we are anyway doing it even in low risk patients for surgery. What we need to see is to change the conversation, who does well with TAVR. Like if you have any particular contraindication for TAVR, then probably that patient could do well with SAVR, and other way too. So that's what we need to see, assess this patient, so suitability of a TAVR. Assessment happens not only in echo, but mainly by CT TAVR protocols. So that is in brief about that. Then TAVR sites in India, about more than 50 sites, and more than 10 sites, 200 plus cases till now, I think. A lot of names are mentioned here, but I think Eastern India also is picking up now. I'm very thankful to all the colleagues across the country, especially my SGPG alumni friends who have referred patients. And Apollo was in news sometime back where we did 5 procedures on one day. Thankfully, the management also should be favoring us to establish such sort of hybrid cath lab and all the necessary infrastructure, along with the proper heart team, critical care surgeons and all. These softwares which can be superimposed in the cath labs initially help for us in delivering the therapy to these patients, but as we become more experienced, they may not be required always, but the initial part of it, whether you get the same CT pictures into the cath lab, you can see how the valve is sitting and how it is expanded, and that initially in the phase where we had to, valve was not expanded, we did dilatations and again did good to this patient. But what is more important than the heart team approach? I really appreciate the surgeons sitting here for their cooperation, because unless our surgical colleagues also support, the program cannot pick up. In general, in India, heart attack, MIs, unstable anginas come to cardiologists, but valve therapy, generally every physicians, all the general doctors refer to surgeons. So unless surgeon is very cooperative, our program cannot pick up. We do have a mixed bag of surgeons, some of them cooperate well, some of them not, but still, because whatever is good for the patients, we need to continuously work on it. I feel the data will be there again, everybody has to fall in place. Initially, when I was NIC chair, this just started the therapy in 2018. There are only 300 plus procedures which are done in that time. Numbers are picking up now from actually 300. Now we have come to a stage, the Pratap presented recently, I think, where 3,000 plus cases are being performed. And Merrill, my valve, I think Indian valve, made India proud, and numbers of them are more. And Medtronic and Edwards also follow. Some of the newer valves like Hydra, Boston valve are all launched, and they're just picking up. And we should be thankful for industry for supporting for all such programs of training and education. As we initially started with only surgically unfit patients, now post TAVR 3, we are delivering this in low risk patients. Why we are very important to understand this is low risk patient with our surgical colleagues can offer best therapy when you are entering that procedure. This patient is totally different. He doesn't accept any of the minor complications too, and he is otherwise good, and he wants to go back and enjoy life. That's why we have to give the perfect results. The 5 golden rules for TAVR in low risk, I feel, could be surgical TAVR should be agnostic to SAVR. It's not that we compete. We actually should be combinedly doing good to the elderly comorbid patients who are favorable for TAVR. And transfemoral axis is what is, all the trial data is there. So unless you are able to deliver this therapy, the transfemoral axis, you can't say that you are good to the patients. Age is important, and TAVR for doing for less than 65 years, only from specific consideration of comorbidities is there, you have to consider it. And sometimes if there is unfavorable anatomy, like low coronary axis or a very hugely dilated aortas or annulus, probably surgery could be preferred. And patient preferences matter, and shared decision making is essential. These are the basic rules for deciding on the patients for TAVR. Evaluation, clinical importance is still there, and where the patient symptoms are there, examination nowadays people are forgetting, but I think heart failure diagnosis, things like that are still very important. Clinically, how the patient have symptoms is important. 2D echo, 3D echoes, peri and procedure, peri-procedure is important, but most of it is by CT angiogram. All of it should become comfortable. I think you should appreciate companies also, the 3-dimensional software coming down and the teaching all the cardiologists. We learned this from Sushil. Every CT, though it comes from the companies, we ourselves again see and analyze what is the size of valve and things like that. Then as this is, we are now posing it as a revolutionizing for aortic stenosis therapy. So we have to deliver it to appropriate needy patients with proper heart team approach and expertise. We do see more of bicuspid valves in younger patients. Probably we are teaching West in this subgroup of patients. Ideally, though when it was started, some centers of excellence were being created to deliver the therapy. But now business dominates again. Competition led to Proctor industry-driven centers. But what I wish at least it should not be done in the centers with no surgical facility, which sometimes is happening and we feel bad about it. Coming to spectrum of patients, initially we were doing only high-risk surgical patients, then it's okay. If patient was anyway not suitable for surgery, you could afford even if some problems were happening, though in that also we should do a good job. But when you're doing this, there will be for less than 65 years, unless there is specific contraindication to TAVR, then you shouldn't be offering this. And some of these high-risk features of TAVR, like whenever there's low coronary height, people put left main chimneys and things like that, but unless there's a specific reason, contraindicated surgery, I don't want that crazy stuff to be done to these patients. And then when there's a narrow chance, high chances of aortic rupture, complete heart block, again you could take the help of surgeons. On the other hand, some surgically dominated centers, some surgeons, we have two groups of surgeons, one surgeon extremely talented, all the surgeons, but even octogenarians, they want to redo SAVR again. That's also not correct. So what is it correct for the patient we should try to do? Why we are so much pertinent about age is for this thing. Less than 50 we anyway favor surgery, more than 75 anyway TAVR. In between probably you have a shared decision making. And why it is important is after valve implant, after 9 to 10 years, you need a second valve. That's how we need to plan this lifetime for these procedures. And when you're dealing with younger patients, then you should be seeing what is yet to come in future. So what is the ideal TAVR valve? If you see, if you ask me, probably lowest profile with good trackability, easy to use. That is 14 French systems, and there are some with more French. My valve, though it is good, slightly more thicker French, but we are working towards 10 French. If it comes, vascular complication will further decrease. And then the valve should not leave any PVL and no less of heavy blocks. Optimal hemodynamics again, there shouldn't be any gradient because we understand there's more than 20 mm gradient, the follow-up events will increase significantly. Coronary axis, immediately it should not be causing obstruction and the follow-up axis should be maintained, especially when dealing with relatively younger patients. And long-term durability of valve is what we are seeing, and you should not be requiring valve-in-valve type procedures soon. And we want a good long-term evidence beta, all this with a low cost if possible. That's what probably ideal valve. See, the valve types, we will know balloon expandable versus self-expanding platforms and annular, supraannular valves there. And I feel all of us should become comfortable with one or two valves and work with the patient's interest in the top rather than getting into any other industry issues. Valve preferences, the 80% of the patients, either of the valves can be used, and you can choose the valve whichever you are comfortable with. Some preferences, just for the sake of understanding, as people ask, is balloon expandable valves generally could be preferred in relatively younger patients because again the coronary access, other things, strut frames are less, and more sicker patients where you need to do the procedure faster because if a fast deployment could happen, probably you could select those. And anatomies like horizontal aorta with post-stenotic dilatations and coronary access issues, and wherever you feel the more chance of heavy block, such patients, pre-existing RVV, LVV, probably first degree aortic block, you could do better with balloon expandable. On the other hand, self-expandable valves could be preferred in elderly patients with narrow annulus, LVOT, severe, where is the chance of more calcification ruptures and probably abnormal hemodynamics, what you are saying, or valve-in-valve. These are some of the situations in which you could prefer self-expandable valve. Just like that, we should have so many people. I think I will, for the sake of time, I will avoid this. These are steps which will be covered soon. I'll just end in 1 or 2 minutes with showing these examples. Then this is a routine patient with bicuspid aortic valve. The sizing techniques and the valve selection should be slightly different. For sake of time, I can't go into details. But basically, this is straightforward post-surgical patient, and then you immediately do good. And if you don't size it, this size was little bigger with the company, but we did expertise before. We did less size, and that's how we could avoid rupture here. Otherwise, they could develop into aortic ruptures. So we need to be careful about seeing the calcium extent and all that. It's again boon to such high-risk patients of 81-year-olds who have multiple CABGs done already with heart blocks, and now he's a doctor himself, and then he didn't want to have anyway surgery. With such patients, this procedure has come out a big boon. For the cardiac CT again should be studied in detail, and we see select the size and other things. The access site studying is also important. These things will be discussed in detail, but proper gain setting and working with the radiologist is important. You could miss all these difficult diffuse type of calcium if you increase the gain setting like this, and on the table you could land in trouble where it gets stuck. So those are some of the things where you should become comfortable with the CT also. Some of these inoperable patients or patients who have porcelain aorta, severe dysfunction, CKD, then post-MVRs, all that TAVR in valve, and all such things could be again tackled. For the sake of time, I'm just rushing you through. And there are definite protocols and how the valves are selected with the apps. We do that. And then sometimes patients with the left coronary artery disease as well as severe AS didn't want surgery again. We tackle left main disease, and then probably in the staged manner you also go TAVR. In one of these patients, post-bioprosthetic valve degeneration, we recommended repeat surgery plus bypass, but he didn't want. So we had to stented the left main with image guidance with optimal good results, and after 6 weeks we did TAVR to him. Post-mitral valve replacement, severe PAH, again she developed aortic valve disease. We thought it would be difficult, but again different planes, you understand the anatomy well, you could offer this therapy and patients did well. Why all we do all this struggle is we want patients to be happily in recovering. This is a lady who was referred from Nagpur, one of my juniors. She went on to vote, and she was very sick on bed before. After procedure, immediately improved and went. This is a sick patient, immediately next day sits comfortably. That's how we are intrigued and like this therapy very much, because finally TAVR works, and the patients and physicians want less invasive therapy. But again, we have to, again, the risk benefits threshold vary with the age. So TAVR is integrated into the treatment algorithm. So what is its future? Probably it will go on increasing further, and then probably bicuspid aortic valve we already conquered, concomitant coronary artery disease, MR, and asymptomatic AS, one thing which is exploding, moderate AS with heart failure, some in future probably high risk severe ARs also could be tackled by this new therapy. More and more such things will be discussed in coming TCT India, July 27, 28, 29. I request all of you to block your dates and be there. Dilip and Panja sir also would be there. I request all of you to block and enjoy this new premises, convention center, Geo World Convention Center in Mumbai, which is a fantastic place, and both academic and none of the other fees will be there for all of you. Thank you once again for the opportunity. Thank you, Dilip, for this. Thank you.
Thank you, Srinivas. That was really wonderful. Nice display of the journey of TAVR from the journey to the real world cases. I'm sure you all enjoyed that. Is there any quick question or any comment?
Dr. Srinivas, I think I would request you to now go into rheumatic aortic stenosis. Since in India, in this part of the country, we have so much of rheumatic heart disease, which is not there in the East and the, I mean US and UK. So let's have some trials on rheumatic AS and
the only problem in having dealing with rheumatic, sir, is because one is it happens generally in a younger population. We don't do TAVR as of now for less than 65 years of age, unless there are specific contraindications. Some people have shown in conferences, I remember from some Arabia, some other countries showing that as by default, because they are not couldn't take up surgery, they did TAVR too. But it's not on the question of delivering it, but the valves, as of now, we have data about 10 years or so. So we're not comfortable putting the same valve where our surgical colleague can offer it and patients do well. So that's how we are not able to do for rheumatic. But the day might come. Sir, surgeon wants to say something. Please.
You see, we welcome all our cardiological colleagues in this pasture of structural heart disease, which we have been tilling these fields since 1950s. From the era of Hufnacle, and from the time that a gentleman called Edwards designed the first tissue valve, if memory serves me right, it was in the late 60s. So we have been playing this game for a few decades longer. Couple of words of caution. In all this euphoria about TAVR, remember one thing, that TAVR is just a different way of deploying a tissue valve. It's nothing else. So all our morbidity benefits, all our mortality benefits, all our procedural benefits are not coming from a fundamental change of physiology or substance. So what we have changed in this time is just a method of deployment Our method of conventional surgical deployment was definitely a little bit more heavy-handed. You have come with a little bit more light-handed, user-friendly way of deploying the same tissue valve. Core issues remain unanswered about tissue valve, and the question we will be facing, you will be facing in the next 5 years are two. Durability is a big ticket item right now, and there are lots of burning questions all across Europe and North America as you go on doing low-risk patients with higher expectancy. In your low-risk substrate, it doesn't necessarily mean young patients. Lower the risk, higher expectancy from the transaction. And in that transaction, it is like a failed romance. We have been sold tissue valve ad nauseum for the last 30 years, giving us, it's like the Duracell-like promise. You put it in, it goes on for ad infinity. It does not. So the 15-year holy grail time period of tissue valves, by and large, has seldom been met. And now with you becoming more slicker and more cleverer, your lower sheet sizes and everything, your leaflets are becoming thinner. So it is the tissue level challenges which will constitute the next milestones, because I'll tell you, a higher than expected number of valves will fail in the window between 7 years plus. 5 to 7 years, I tell you, is a terrible time for tissue valves. We've seen it with Perimount, we've seen it with your Epic, we've seen it with Trifecta, we've seen it with all the things you have. So how you're going to address it, how the community is going to address it is one question. Durability, promised durability is one thing, and observed durability is yet another. And the second point is, what is a nightmare for the surgeons is, not many of them are happening, but some of them are. Taking a valve in, valve out is not desperately difficult. A valve in, valve, taking out a valve in, valve is not desperately difficult, but taking out a primary TAVR, God save you. This is something, don't think about the disasters now. In selected cases, I wrote the two of the nastiest reviews against TAVR in the years 5-7 years back. That is water under the bridge. I think it should go out the way it is. Please sit with the industry and issue and address the tissue level questions. There's a trial going on in India now. I was not brave enough to participate in it, about polymer valves.
Yeah.
Because obviously you cannot use mechanical valves in TAVR, that's out of the question. The data, mind you, of mechanical valves are improving. Look at Goldstein's data from California. He's presented pretty smart data about mechanical valves. Polymer may be an answer, we don't know yet. 3 centers in India are enrolled for the polymer valve trials. But my basic, all of us put together, we have to drive the industry harder to improve the tissue, the substance they are giving. I put it in one way, you are putting it in another way. But the mother tissue remains the same, and that over the period of last 3 decades has not lived up to its durability.
Okay.
We have a lot of improvement to do over there, and we as surgeons, we have to learn new tricks, because whoever has been faced with this pretty stiff challenge of taking a first-time TAVR out, it's nightmare. We still don't know how to do it.
Actually, sir,
Thank you
most of the guidelines has included only the surgically directed patients initially. But with our expertise, it is getting expanded, but no guideline is accepting the younger ones. So till the surgery is #1 choice for most of the patients. But those who are very...
The industry, look, the industry,
Sir, industry will go in one side and we have to think.
The industry was in pretty troubled waters in facing up to their assurances about a durability. Whether it was a porcine valve, whether it was an equine valve, what kind of... See, we've been in this business longer. We've been in this business longer.
We understand,
Okay,
sir, what
Dr.
you're
So
saying.
we've gone through the chocolate flavored valves, the strawberry flavored valves, the anti-calcium treated valves, everything. But the question is, the durability goalposts given over the last 3 decades
Sir, there
for
should be a
tissue valves have not been met.
Okay, Doctor, you
TAVR valves will not be any different.
No, sir.
Post-marketing
I'll just
surveillance.
take, I'll just
After
take,
okay,
using,
Dr.
sir.
Sarkar, your points are well taken. So you keep in mind, you have proceed accordingly.
No, true.
And there
I'll
is very
just take half-
important only, yeah.
I'll just take half a minute, sir. As you said, the research is going on to use polymer-based tissue valves, and Foldax or some company, I think recently one of the centers in Hyderabad was also part of it. And if it works, it is actually no man is involved. Everything is done through robot. That's what they were telling. If it happens, it is more long-lasting. It's good. But surprisingly, though surgeon feels that surgical valves and TAVR valves should behave well, but in the trial data, actually core valves performed better than the surgical valves because of supraannular nature and better hemodynamics, I think. They are not placing exactly in the annulus. It is actually a step ahead of the surgery because that long-term 10-year follow-up data showed that there are less of gradients, less of degeneration happening with the core valve compared to surgical valve, though not very significantly different. But that sort of thing is unacceptable. We are not thinking. And annulus sizes, which were very small, surgeons used to put 19, 20 sized valves. We are able to put 23, 26 sized valves in those patients. That's how slight advantage could be there, apart from the handling and patient less complications. But we agree, durability we need to see it further. But we are happy at least at this point of time comparable, and some fact some trial showed slight benefit because of the supraannular nature of the valve which is being put, bigger sized valve and better hemodynamics.
Thank you, Dr. Srinivas, sir. What a way to begin the structural heart conclave: promise, deliverance, and caution. So with this, I think we had to prepone Dr. Kunal Sarkar's talk, yet he has to catch a flight, so I invite him for his lecture. And in the meantime, can we have some comments from whether the dry tissue technology is going to deliver some more durability to the valves? Anyone? Dr. Manik?
Dr. Sarkar will talk on the surgeon's take on the high-risk patient and degenerative mitral valve. How can we manage by this thing? And okay, Dr. Manik, please take.
So now we have dry tissue technology for the TAVR valves. There's one valve called Vienna valve which has come up with that, and we don't have enough data. But yeah, also a trick valve with a tricuspid position, which is again with dry tissue technology.
You have dry tissue for surgical valves when you have Brasilia.
Only point that is in our country, that is, if you take the patient of the above 65 years old, that case is most of the Indians, the frailty is there. Second thing, the corona, that is femoral arteries, access also very small artery size, third the cost. So thanks to our different industry, 2 industries coming in our country, and the SMT as well as the Merrill. So our indigenous valve, and even China, there is a 4 companies there. They're the indigenous valve is available in China. So Dr. Sarkar, please start your lecture.
Thank you, Dr. Paja. Once again, thank you for the opportunity. I wanted to talk to you about an issue which there is less euphoria about, because not all of life constitutes of good news all the time. There is one area in which I think we as a community remain blissfully confused, and that area is how to handle poor left ventricular function, and especially focusing on the problem of ischemic mitrals. Now, there is some record of measurable human life expectancy from 16th century onwards. Beyond 16th century, there is no human population tracking data. And from 16th century onwards, if you see that there has been 2 spurts in improvement of human life expectancy. One spurt came over here, and that was the beginning of the Industrial Revolution. And the second spurt came over here, and that we believe was largely contributed by the advancement in cardiovascular interventions. Because cardiovascular interventions over here coincides with the big jump in human life expectancy overall. What is the global cardiac revascularization scenario? In the global scenario, we believe about 800,000 about 800,000 coronary revascularization happens globally, and about 4 million coronary percutaneous interventions happens globally in a ratio of about 1:5. And in this ratio of 1:5, 20 to 30%, I'm not sure about your intervention data, but I'm reasonably sure about our coronary surgery data, that about 20 to 30% of all the surgical cases are people who are defined as poor left ventricular functions. Now, in this area of poor left ventricular function, we still have many riddles to solve. There are two issues. What is the evidence in front of us in severe LV ischemic dysfunction, and how are we doing with ischemic mitral regurgitation? I just want to touch with you briefly about few of our own surgical interjections in our own work, which rather than giving us clarity has given us more confusion. And one was the great Stitch trial, which concluded in 2011. It happened between 3 years, from 2008 to 2011. Eric Velasquez got a few million pounds funded for the study, and he was basically in a randomized fashion looking at the influence of medical management with CABG in poor left ventricular function. I will not go on for yards and meters on this. The conclusion of the Stitch trial, honestly, to the great disappointment of the surgical community, was the bottom line was that there wasn't buckets of improvement in poor left ventricular function with CABG. Whether you looked at the all-cause mortality, whether you looked at all-cause mortality as treated, as per protocol, whichever, it failed to reach surgical statistical significance. Now, this resulted in an enormous amount of turbulence in the surgical community, because we as surgeons always tended to believe that we manage poor left ventricular functions very well. A Stitch trial, which is still to date one of the largest randomized exercises with surgery in poor left ventricular function, looked at the influence of viability studies, and once again the conclusion of that was pretty ambiguous, that with viability studies maybe your mortality post-procedure could be a little lower, but then again not a sea of difference. So this leaves the entire handling strategy of poor ischemic cardiac function with or without MR in a kind of zone of uncertainty. And all of us in our clinical practice who handle this cohort of patients, we know they have limited survival. We know that this is a complex disease, and whichever way you try to skin the cat, we are going to run into some trouble or the other. Now, where do we stand today? In 2020, in JAMA, the surgeons got very upset with the conclusions of Stitch trial. There was more papers written criticizing the Stitch trial than the Stitch trial itself. And there were a lot of huge meta-analysis. One of these came out from Mario Gudino in Weill Cornell. And Mario Gudino, a good friend of mine in Weill Cornell, looking at more than 12,000 patients, came to the conclusion that surgery was better, giving better long-term survival, etc. But still, friends, even as a surgeon, you cannot put a retrospective meta-analysis and a randomized trial on the same platform. So confusion persists. Ischemic mitrals. Now, where are we getting with ischemic mitral? So bad ventricle plus bad coronaries basically is bad news. With ischemic mitrals, I'm afraid to say that in a peer group community, let us realize that we have actually taken a few steps backwards. Now, why do I say so? Because with ischemic mitrals, all of us are aware of the fact it can happen in about more than 40% of post-MI patients. There is LV remodeling, dilatation, the valves get all clobbered out, it's a deformed valve. It is defined to be a ventricular disease rather than a valve disease, and most of these people will end up having triple vessel disease. Ischemic mitral is a rather far more common condition than we think it is. So these are more of surgical interest, all the various mechanical, anatomical distortion that contribute to the mitral valve malfunctioning. If you had pre-existing MR, if we are in a situation of incomplete revascularization, if the left atrial size is large, if patient has renal failure, if we have not given the patient guideline mandated medical management, and in the presence of significant left bundle branch block, all these factors make the clinical situation worse. So the surgeons came to a rather simplistic conclusion. The surgeons thought, fair enough, the mitral valve is tethered, it is leaking. So we went on doing hundreds and hundreds of what is called undersizing annuloplasty. So you were revascularizing these patients, and along with 2, 3, 4 grafts you did, we went on pump and did an undersized annuloplasty. This gentleman, Stephen Bowling from Ann Arbor, was really the champion of undersizing annuloplasty, and all this was happening in the era of 2008, 9, 10, and we as surgeons thought that great, we are doing a great job, well done, we were going home very happy. So much so that from the Imperial College London, one of my best friends, Prakash Punjabi and John Chan, released this paper called the Rhyme Trial in 2012. Rhyme Trial in 2012 is considered to be a hallmark moment in publication of what is the effect of surgery on ischemic mitrals. And to cut a long story short, Rhyme Trial looked at peak VO2 consumption, looked at remodeling, looked at the presence or absence of MR at around 1 year, and we were all very happy that all these parameters looked good, and we concluded that well done surgeons, you have done a good job for ischemic MR, these patients should feel better for it. But well within a year, within 1 year of 2011, when Rhyme Trial was published, came out once again a very blunt piece of, not within a year really, it took a few more years, 2016. Mishler published this bombshell, which is called the CTS NET study into ischemic mitrals. And Mishler's data really shook the surgical community, because he just followed up this cohort of patients for 2 years, only for 2 years. And following up these patients for 2 years, severe ischemic mitral regurgitation, having mitral valve repair, followed for 2 years, who looked pretty good, pretty suave, pretty clever at 1 year, within the 1 to 2 year window, the results were dropping. We saw that the mortality was not significantly increased, MACE rates were not tremendously better. So the surgical illusion that we were doing patients tremendous benefit by repairing ischemic mitrals were completely rubbed off. And having rubbed it off, what happened basically is that CABG, after, CABG and mitral valve repair definitely proved it gave the patient more durable repair. MR was less, residual MR was less, but this did not show within a 2 to 3 year old period that the advantages in terms of mortality, MACE or readmission. And plus you have the specter of immediate post-operative problems. So after Mishler exploded this bomb in the surgical community, people started out of the, I'll conclude in a minute, out of the woodwork, and everybody started saying that, look, we are not as clever as we thought we are, and ischemic mitral should be addressed with caution. So all these publications came up. They followed Mishler like the Pied Piper of Hamelin, and one publication started coming up after the other. Now what happened? This is of relevance to all of you. This is of relevance to the surgical community, to the cardiological community. Please remember that the definition of an ischemic MR has changed. You had a one set of definition in 2003. In 2003, your EROA measurement was more than 4 square centimeters of what was considered to be significant. Then when we got the bad news, we realized that, look, we really have to up the bar. We cannot have such a low threshold for repairing these mitral valves without tangible benefit. So the EROA in 2014 guidelines was revised to 2. And because 2014 was the time when we were all very happy. So it was dropped down to 2. More and more patients were having ischemic mitral repair. And when the other set of data came out, in 2017, the bar is now raised up once again, and the EROA definition has changed. So when we communicate in our cardiological and surgical community, we should be on the same page, aware of the fact that what actually constitutes a significant ischemic MR and why has the data changed. The parameters have changed based on the outcome. It has not changed because of some whims and fancies. And this is exactly the confusion that pervades in your data as well in the MitraClip and the Co-op. Because in the MitraClip and Co-op data, when you go back and see, those two data, very expensive studies, have really compared apples for oranges. One chap has taken the cut down as 2.0, the other chap has taken the threshold as 4.0. So my appeal to all of you is that this is a pretty nasty set of cases and we must not get confused at this stage. So 2017 guidelines that came out gave us a different set of guidelines altogether, and translated in plain language what it means is, if we have moderate MRs, let us be aware what the current echo parameters are. Surgeons have to select the cases more stringently. If the mitral regurgitation is severe, there is some role for mitral valve replacement that cannot be thrown out of the window altogether. So for all of us, we take home this message that coronary artery disease undergoing CABG with moderate MR be selective. We do not have an automatic knee-jerk response for mitral valve repair. Where we think the MR is severe, we have to select the technique, either go for a repair or replacement. Coronary artery disease not requiring CABG, mitral valve intervention is not required. And whenever we manage these patients medically, we have to be very mindful of the fact that we are giving them proper guidelines mandated medical management. So even in the 2021 AHA guidelines, now there has been a storm about this set of guidelines. I am one of the co-authors who on part of the Indian Association has objected to the 2021 guidelines. It has been published, and 2021 guidelines have actually downgraded the role of CABG both in normal ventricles and in poor ventricles, and needless to say, we surgeons are not sleeping very well because of this. So let us persist that not all of life is very simple. In not all of life do we have the necessary amount of equipoise we want to. And our mature group of clinical community put together will really have to exercise a sense of judgment and discretion in handling these people with coronary artery disease, with post-infarct LV dysfunction, with significant mitral valve disease. It remains a sticky wicket to bat on, and I really hope, based on skill and evidence, that the air becomes a little more clearer in the future. So a word of caution for all of us. Thank you very much.
Thank you. Any questions I want to discuss? Anyone? Ravin? Any question?
So very quick comment from Anil. Welcome to Calcutta. Hello. So I really was very impressed with it, as usual. Yeah, it's on. So I think these are very sick patients. And we are trying to draw conclusions from sick patients without having structured data sets in their analysis. We are trying to draw conclusions and trying to see the disparity between the stitches on one hand and the revived basis 2 on the other hand. Whereas,
No, and sir, one thing, there can only be one conference going on. Okay, thanks. Yeah. I was having some banter at the back.
India is a popular democracy.
Yeah, sure,
there are conferences and conferences, so it's okay. So between the stitches on one hand, between the evolution of the stitch data as we felt it, as we saw it coming, the initial data, the reanalysis and the follow-up with stitches, and then my friend Divakar Pereira, when he did the revived basis 2, and it's such a tedious recruitment, such a tedious analysis, demonstration of viability with using the best-in-class techniques. I mean, we can suspect, but MR techniques being used, such great randomization, and look at the outcome. So I think we are trying to split too much of fine hair here, and we are trying to draw generalized conclusions which are not really appropriate. It should not take away the personalization of care. So I think Paul Grayburn, when he was analyzing ischemic mitral regurgitation, especially the differences between coapt and micro-FR, he introduced a terminology of proportionate and disproportionate.
I know, yeah.
So I think we need to sift the fine print. We need to understand that every patient needs to be individualized, and too much credit or discredit has been given to guidelines.
Yeah.
In my humble opinion.
Yeah, to put it even more, even in a more rustic air to it, you see, the question is our species, both the plumbers and the fixers put together. My point is that we are looking a bit stupid at this point of time, because what are we handling? We are not handling something very esoteric. You are handling 40% of the clinical community post-infarct, and you are handling 40% of MI in a situation where we believe, 1 lakh MIs happen in this country every night.
Okay.
So our question is that, say, amongst ourselves, whether in our data sets we can come up with a simple set of working formula how to handle this group of people.
Unfortunately, the touch points required for creating a data set like that.
Absolutely, because otherwise through all this razzmatazz of device, materials, meetings, the more we talk, the more stupid we appear to be. That's our problem.
Okay, Kunal, excellent presentation. Rightly I point out the RHYME study, that is the moderate MR with multiple coronary disease and statistical shows the viable myocardium. Definitely annuloplasty along with the CABG is a good result. But if there is some severe MR, that case with comorbid condition, that case the COAP study shows mitral cleave is beneficial. Both the particularly survival time increase and may also drastically reduce in cases of COAP. Thank you very much, excellent presentation. Next speaker.
So now may I invite Dr. Manik Chopra for his talk, and by the time he is fixing his presentation, stitch showed benefit after 5 years of the trial. Initial 5 years, medical arm and CABG arm were both equal. And our revived trial, let's see after 5 years what happens. So, yeah.
Okay, Dr. Chopra, please present your talk on the image before the TEVAR and 3-month CO and other things. Dr. Manik, please.
Thanks a lot for this opportunity, Dr. Dilip, and my regards to all the seniors and my colleagues. So the topic here is imaging before TAVR, 3-month CO and other software analysis
So CT, we know that we would need a CT heart TAVR protocol before we go for to decide whether this patient is for TAVR or SAVR, and second, if it is for TAVR, then which sort of valve and which route. So CT TAVR protocol, I would like to discuss it in three subheadings. One would be the guidelines for acquisition, what are the available softwares, and what are the points which we need to assess on CT scan. Now regarding the guidelines for CT acquisition, the cardiac multi-slice CT scan would be 0.5 mm slices, contrast enhanced, ECG gated. Vascular access would be 1 mm slices and contrast enhanced. Many times we get scans which are done at multiple centers, and it's sometimes difficult to communicate even to the radiologist and the technician as to what we want. But I would tell a simple thing: the CT coronary angiogram is very popular nowadays and is done at most of the centers. It's exactly the same protocol which we are going to use. The only thing is CT coronary angiogram is mainly in diastolic phases because they are best seen in diastolic phases. We just want the same data to be reconstructed in both systolic and diastolic phases. That's it. For the peripheral angiogram, it's exactly as the aortogram which they were doing since ages. So that these two lines would make the job very simple for the people to understand as to how and what is the prerequisite for the scans. It's best to ask them to transfer the sequences, one which is plain, which is without any contrast, so that you can appreciate the degree of calcium at the valve leaflets, systolic phase, and diastolic phase, and the peripheral angiogram. Systolic phase, because systolic phase is the way to analyze. It gives you better numbers, larger numbers, and that is the number on which you are going to decide the valve size. Now, the available softwares, we know that there are multiple softwares. The most popular and the initial one was Interventional, which comes from Pi Imaging. We also have Mac-based Osiris system, and we also have 3D planar reconstruction platforms available on all the CT scanner machines which are in present day use. Some also with TAVR specific softwares. All these programs just use the same 3D planar reconstruction programs and somehow make the things more simple. I would now come to the points which are to be assessed on CT scans. So as we said, first, what is the phase of assessment, whether it is in systolic or in diastolic. Second would be the type of valve, whether it is tricuspid and bicuspid. And then we should remember these 10 standard pitches, which I am going to discuss next, which would be annulus, LVOT, sinus of Valsalva, STJ, LCA height, RCA height, degree of calcification, angle of implantation, aortic arc, and the peripheral angiogram. So apart from that, there are many other things which we would like to see, like LVOT calcification, ascending aorta, what is the cusp overlay view angle. There are special scenarios like bicuspid valve and valve of the previous mitral valve process, with the mitral valve processes, assessment of chances of coronary artery occlusion, assessment of alternate access if the peripheral vessels are smaller, assessment for TAVR in young patients keeping the lifetime management in mind. Also, we can see the coronary anatomy and also CT chest and abdomen. Whatever is available, we should look for any other incidental findings which are there. For example, if you have an incidental carcinoma sitting somewhere, then you should check with the oncologist regarding the lifetime regarding the survival of that patient. Now, how do we see it is in systolic and then diastolic? The immediate left-hand image you could see is similar to a 3-chamber view which we do on echo, and you can easily see the mitral valve which is closed. It's a still frame from an echo view. You can easily see that, and you can see the LV is contracted, the mitral valve is closed, and this tells you that this is a systolic phase. Same if you come to or any diastolic phase or end-diastolic phase. If you look at the extreme left image, you could clearly see again a still frame which is similar to a 3-chamber view of echo, in which the mitral valve is completely opened up. You see the LV slightly larger in size, it's not contracted, and that is how you would say that this is diastolic. It's important to check that, because sometimes the the phases which you get are from the RR interval 10, 20, 30, 40, 50, 60, 70, 80, 90. Routinely 30 and around would be systolic and systolic, 70 and around would be end diastolic, but it also depends upon the heart rate of the patient. Sometimes they do not match perfectly. Now, why do you want to assess in end systolic phase? Because it's considered to be more accurate. I would say that we should try to analyze in both the phases. The numbers are higher in end systolic phase, but they're typically higher, but sometimes it might not be the case. And you should also compare it with end diastolic phase to assess whether it is accurate, and it also helps in sizing. For example, if your end systolic and end diastolic numbers are almost equal, or maybe the end diastolic one is 1 millimeter less, then you know that mostly your analysis is accurate. If it is not matching, if it's not like that, then probably you need to double check. And if it is still like that, then you need to titrate your valve size so that it is either not too large for an end diastolic number or not too small for the end systolic number. Now, which type of valve which we are dealing with? This is how the tricuspid valve looks like. You scroll from the bottom to the top, and these are the three leaflets with calcium. And we know the bicuspid anatomy. Type 0 is with no raphe. Type 1 is one fused raphe. LR, that would be LRN or NL. And type 2 when there are two raphes which are being fused. Now, you should scroll from bottom to up, because sometimes it would be more bicuspidish lower down and becoming tricuspidish higher up. Sometimes it is tricuspidish lower down, raphe then, and then becoming bicuspidish. Now, these are the 10 standard pictures: annulus, LVOT, SOV, STJ, LCA, RCA, coplanar view, calcification, aortic arc, and peripheral axis. This is how the aortic annulus looks like, any system. It gives you minimum, maximum, average, area derived and perimeter derived numbers, and area and perimeter derived numbers. And we need to understand that the shape, whether it is circular or oval. Earlier we considered that it would be circular, but many times it is basically oval. The calcium, where exactly it is sitting, the amount of circumference of the calcium involved, the thickness involved, the extension into the LVOT, whether it is sharp or flat, and what is the location. For example, if you have a flat sort of calcium, then it is less likely to create annulus injury. If it is sharp, spiculated, more likely that it will lead to annular injury, more likely leading to PVL, because your skirt is not going to be taking that sharp bend. Of course, it also depends upon where exactly the location of calcium is. If you find the calcium in this quadrant, which is facing towards LAA, here, if there is a calcium, then if it moves out, goes into the pericardium, leading to pericardial effusion. If you have something in the front, it goes to the septum and it leads to a VSD, which can be taken care of later. If it is somewhere over here, it leads to a Gervold sort of defect, which could be again taken care of later. But the calcium which is sitting in this area is something which you should be very scared of. Also, if it is extending more into LVOT, more chances of PVL, more chances of annulus injury. What do you do with the minimum diameter? It helps in size, which pre-dilatation balloon you need to use. Typically, in self-expanding ones, you would like to go with the minimum diameter, but in balloon expanding technology, since you are finally going to go up with a size of balloon which is more than probably your annular size, you can probably take slightly higher size of balloon also. Area and area derived diameters are basically for balloon expandable valves, and perimeter derived diameters are mainly for the self-expanding ones. This number, so basically the annulus is going to help us in telling what is the type of balloon, what should be the size of valve, which type of valve. We also know, as was discussed earlier, that in self-expanding ones, if the annulus is small valve and valves, you would probably go with self-expanding supraannular technology, which would give you better area. However, patients who are bicuspid and most of all the regular sizes can be where you need good amount of radial strength, balloon expanding valves, especially those with very extremely large annuli in which you are going to use XL sizes, then balloon expanding is going to be better. So the same also goes with LVOT, because the LVOT is measured just 2 or 3 millimeters lower down. So whatever your THV is going to do to the annulus is also going to do to the LVOT. Sinus of Valsalva again is a standard part of all the upsizing charts, and also tells you about the chances of coronary occlusion. STJ, again we have to go with the mean number, because your balloon, pre-dilatation balloon as well as the balloon expanding valve balloon is going to touch this area for at least 3 or 4 seconds when you inflate, and if it has calcium, then probably you have some chances of aortic injury there. LCA and RCA heights, we typically would measure the lower numbers, but it's a good idea to measure the top also, and it tells you about the idea of the coronary occlusion which is going to happen. This is a coplanar view which is standard for balloon expandable valves. Earlier it was also used for self-expanding one, which has now switched to RL Kasper-Welle view, because we can deploy the valve higher and the rates of pacemaker become lower. The amount of valve leaflet calcification, we know mild, moderate, severe. We need to know the distribution pattern, where exactly it is more, so that we know where the valve is going to shift, whether it is enough for valve anchoring or no, and this also would sometimes decide what size of pre-dilatation balloon which you are going to use. And you can see the aortic arc. Sometimes you need see a very acute sort of bend here, which would be sort of a nick, and we know that we need a system which is more flexible to travel across. Either you have to use a very stiff wire to cross, or a very flexible system to go. Peripheral access, depending on what name 3 numbers, one at the level of bifurcation, somewhere in the external iliac, and then in the common iliac, so that the minimum diameter should be taken care of, so that you decide what system should be used. Because small there are systems which can go through small access, and of course, if it is not possible, then you have to assess the alternate access. This is what we have discussed, and other points like the amount of LVOT calcification. If more than calcium, more the chances of annulus rupture injury, and coronary anatomy. Of course, if you can assess on CT scans, you avoid a conventional coronary angiogram, and chest and abdomen findings also. Thank you.
Thank you, Dr. Chopra. Any question from the audience and from us?
So, suppose a patient has a maybe 11 or 8 to 10 millimeter coronary height.
Yeah.
So, do you routinely go for a membranous septum length measurement on CT, or you do specifically those patients where coronary heights are challenging?
So, coronary heights as such, what is given in Tremencio report is mainly the height which is measured in stretch view. And the stretch view is a view in which the center line is curved and you have a straight annular plane. Now the valve never sits in such a way. Valve is going to sit perpendicular to the annulus. So if there is a curved line, you get a stretched view. If you have a straight line, you get double oblique view. And typically the more the curvy the aorta is, the numbers might vary. You can imagine an aorta like this, and you say LCA around 7, RCA around 11, and you straighten it. LCA becomes 11, RCA becomes 11. So you get good coronary heights on CT scan report, but when you go ahead and do the valve deployment, and if especially in bicuspid valves, you suddenly find that the LCA is appearing like as if it is 7, because actually it was 7, and you just looked at the stretch view and you don't have the idea as to what is going to be in the double oblique view. The same thing is for the thickness of the valve leaflets. Maybe the heights are 15, but bicuspid type 0 valves, the leaflets are so high, sometimes they are going up to 17, 18. The idea is that you measure where the commissures of the native valve end, because even if you take a surgical valve, the leaflets are going to stand tall up to the top of commissures. So you understand where the commissures are ending, and that is the height till which the valve is going to go up. So if it's up to 18, you have to accept that it is 18.
Yeah, what about membranous septum length, measurement? Do you routinely do it, or
Yeah.
you do it at, challenging patients where coronary heights are doubtful?
Almost in all the patients, because what I see in bicuspid patients as well as in Indian patients, the membranous septum is routinely quite short. Of course, it's not perfect analysis, because for membranous septum to be analyzed, we need good opacification of RA and RV, so that we can decide that this is where the membranous septum ends and the muscular septum starts. what scans we get, these portions are not very well opacified. Sometimes they are faintly opacified, so we can make a rough idea that, okay, if it is like 4 or 5, we are more than happy. If it is less than 3, we are not happy.
Okay, if there is a overlap of the valve, particularly if there is a overlap of the valve, that case is better result. Why it is? New reports come, no? It's an overlap of the valves. That case is result of the valve is better. It reduce the peripheral leak and regurgitation, everything, all complication less.
Overlap, and you mean to say valve and valve? Or?
Yes, valve, yeah.
So if valve and valve as such, you have a valve frame which is already stitched, and most of the times there is no PVL with the surgical valves, and when you put a valve inside that, the whole of the surgical valve leaflet is going to stand tall, and whatever neo skirt whatever skirt we are going to give in transcatheter heart valves, actually the whole surgical valve leaflet becomes outer skirt, and that's why the chances of PVL are very less in those cases.
Okay, thank you very much for the excellent presentation.
Thank you.
Dilip, next one. Who is announced the name?
Thank you so much. This is end of the first session. We will go with that on the second session. Thank you so much, doctors. Big round of applause.
Speaker is absent, no? Other two speakers absent.
Yes. On the second session, we will be starting with that. Thank you so much. We move on with the second session. As coordinator of the second session, I would again like to invite Dr. Dilip Kumar, sir. As chairperson of the second session, we have Dr. Arup Das Viswas, Dr. Dipankar Mukherjee, Dr. Monojit Lodha, Dr. Uttam Shaha, Dr. Ranjan Sharma. I request all the chairpersons to please come on the dais. Dr. Arup Das Viswas, Dr. Dipankar Mukherjee, Dr. Uttam Shaha, Dr. Monojit Lodha, Dr. Ranjan Sharma. Requesting all the respected doctors to please grace the stage as the chairpersons. As discussants of this particular session, I would like to invite Dr. Orijit Ghosh, Dr. Ayan Kaur, Dr. Amit Malviya, Dr. Abhirup Sinha, Dr. Rituparna Barua.
So, what a fantastic first session we had. So, second session is about to begin, and may I invite Dr. Anant Raman to give his presentation. And we have a whole lot of topics on tower coming on the way. So, we'll be ready for many questions and interactions.
Good morning all, and firstly sincere thanks to Dr. Dilip Kumar sir for this fantastic opportunity to be back in Calcutta. It's almost more than 20 years since I've been here, and thanks to the organizers. I'll take you through the next few minutes on what is this, what we are talking about, commissural alignment, what does it mean and why is it important, and how can we do this for self-expandable and balloon expandable valve both, and what is the significance of this. How many of you do currently TAVI? Just put your hands up, please. Good. So we'll take it very basic. When the surgeons put the valve, they align the commissures. Yeah. So that is what you have got, the sort of valve commissure, and you have got the processes commissure. The surgeons will be able to align it so that you get coronary access nicely for the left as well as for the right. But when we do the TAVI, it's very difficult. The initial stages, it's been very, very difficult. And subsequently, we have designed some certain ways for the self-expanding valve to align the commissures. If you don't align the commissures, if the commissures fall opposite to the coronary, like this one, then accessing the coronary becomes very difficult, and also coronary obstruction risk is very high. So these kind of, now how much misalignment is acceptable? Most of the times we'll get 0 to 15 degrees, that is quite acceptable, easily you can access the coronaries. But when you reach to the stage of moderate to severe misalignment and these tabs appearing just opposite the coronaries, then the re-access rate is very low, it becomes very difficult. So for re-accessing, it's very important, and to avoid further obstruction in a further sort of tab in SAV or tab in tab, all those things are futuristic. But the TAVI you are putting in terms of the durability of that particular valve itself is dependent on whether you get commissural alignment or not. So for a self-expanding valve, re-accessing is very important, and your commissural alignment is very, very important. And also for reducing the paravalvular leaks, other associated things, and future access, and also valve durability is very much dependent on this commissural alignment as well. Coronary access, obviously, whether you do TAVI or not, all interventional cardiologists need to know how to re-access coronaries through a TAVI valve. Even if you are not a structural person, even if you are not somebody who will be doing TAVIs, you need to know. And that's why it's important to understand these different valves and also on how to access the coronaries. Majority of the issues that will come when you access the coronaries is, apart from the one I said, commissural alignment, it also depends on the native leaflet and how much depth you put the TAVI valve in, how much the sinus width is. All this will affect in terms of your coronary obstruction as well as how you can access it. So all these parameters you need to take into account when you do the CT scan. Specifically about the commissural alignment for future valve, if you had a balloon expandable, if you're going to put any of the self-expandable inside that, you will need to have a proper commissural alignment so that you'll be able to do this tab in future without any difficulty. So if your valve, obviously it's too deep or too high, that also will affect it. If it is too high, if it comes across the coronaries, then accessing is difficult. If it's too deep, then you might get a paravalvular leak. This I'll skip. What can be done if there is a malalignment and if there is a leaflet across? You can lacerate it, you can balloon lacerate it, you have got shortcut devices that is coming up which you can do. Going to the nitty-gritty of how you do in terms of commissural alignment for a specific self-expandable valve, the most widely used valve, the Medtronic valve. Obviously you see this, there is a C tab which holds the valve. You got two tabs, one on either side. So this one is marked with the open C. That's how we load the valve. And 90 degrees opposite to that, there's a hat marker. In fluoroscopy, you can see the hat marker. If the hat marker is on the outer curve or center front, that's perfect. You will get 80% of the time commissural alignment. If your hat marker is in the inner curve, you just go back and change the orientation and come back in again, because that is as simple as that. So that hat marker, this one we can see after deployment. You will not be able to see before deployment. So this is what is important. So what we do, how to get this, you get the flash port around 3 o'clock as shown there. When you go, you take the hat marker on the outer curve. When you come down, your hat marker is here, outer. When you go to the cuspal overlap view, it will be front. So when you align all these things, 80% of the time you will get commissural alignment. And that's what this picture shows. If you get it in the inner curve or center back, which is the red color, you are in trouble. If you get it in outer curve, anterior, you are fine. So that's what this graph shows. So again, same thing repeated, outer curve, anterior, 80 to 85% you are fine, inner curve, posterior, just you will not get alignment. So re-accessing, if you had a commissural alignment, 80% of the time you can re-access. Balloon expandable, because of the short frame height, you can re-access more than 90% of the time. So in certain cases, this does not work. You take the flash port at 3 o'clock, this particular case, because of the way the aorta and the horizontal as well as the sort of widened, you see this tab marker is in the inner curve, it's not in the outer curve. As you come down also, it's in the inner curve. Please don't deploy this valve in that position. You go back to the descending aorta, you rotate it. Even though you started with 3, you rotate it to 10, 12 o'clock, you make sure it's in the outer curve, and you come in the outer curve. So outer curve and depth, and then deploy it. So you get a perfect commissural alignment, your C-tab is in the inner curve, and you can access the coronaries. So that flash port at 3 o'clock, going in, you check it in the descending aorta, make sure you are in the outer curve, otherwise you rotate it. So it's very important. And you will get good commissural alignment. You can do this for all self-expanding valves. All have got different tabs and all have got different positions. So 3 o'clock for Medtronic and 6 o'clock for Accurate Neo and 12 o'clock for the Portico. And also there are other additional markers you can use for commissural alignment. For balloon expandable, at the moment the Sapien 3, it's very difficult. 50% of the time you will get misalignment. But the Sapien 4 is coming up with the new tab marker there, as you can see. If you keep that anterior prior to deployment, you will get commissural alignment. It's the same with the MyVal. The current MyVal you cannot do. The new generation octa-core is specifically designed for commissural alignment. You have got a marker there, depth marker and tab marker, and the catheter has got this aligners. You keep it up, and there's a specific kind of right coronary and sort of CT-based assessment and alignment. With that, you can get more than 80%. I just skip that for the purpose of the time. You will be able to align this using the clock face, and this particular study that was done in 30 patients shows that 80% of the time you can get commissural alignment. So commissural alignment can be done, and in bicuspid cases, coronary alignment can be done based on the CT-based alignments, and more than 80% of the time you will get it, and you can re-access the coronaries. So you have done a case, you have done a perfect commissural alignment, you want to re-access the coronaries. How can we re-access the coronaries, especially in a self-expanding valve, because that's what we are worried about. The self-expanding valve, as you can see, you got a nice sort of sealing zone, you got a waist, you got a wider zone. These cells can take up to 10 French. As long as you get a good commissural alignment, it will easily take up to 10 French. How we do it? First, you perform an iotogram. Unless you had a CT scan beginning with, you perform an iotogram. You see how these are aligned. You see whether that particular case had a commissural alignment, and you see where the coronary is. You take an orthogonal view. You see the origin of the coronary. Once you've done that, this is how it should be. So your coronaries is there. Catheters, previously we used to kind of confuse ourselves. Now you take the catheter what you normally use. In some cases you go 0.5 less. Otherwise, most of the time the catheters you normally use from radial and femoral is more than enough. You don't need specific catheters for re-engaging. Once you engage it nicely coaxially, this is good, this is not good. If you go down and come up, it might give a lot of difficulty. Disengaging also cause a lot of trouble. So it has to be coaxial, it has to be along the ostium of the coronary. And sometimes if there is difficulty, you can use a wire, over the wire a guide extension, and over the wire you can railroad the guide catheter. So these are the techniques you can use to access the coronaries and disengage safely as well. The way you engaged is the way you disengage. Do not remove the kit, all of it. So if you had a guide extension and a wire, disengage over the guide extension and wire and don't pull it out. So these are the steps. So do an iotogram, select the catheter that is coaxial, approach very coaxially as possible, and then engage and disengage over the kit rather than just pulling on its own. Most of the time the catheters you use will find workhorse catheters. Occasionally you have to downsize by 0.5. So this is a case, I did in 2013, more than 10 years ago. There was a first primary through a core valve in the world, and obviously this patient had TAVI 1 year before that, systemic sclerosis. The TAVI was done in Cardiff. I was in Cardiff at that time, and patient presented 1 year later with significant chest pain, ST elevation, AV or ST depression. Again, you follow the steps. First thing is you do the iotogram. You can see even then we were getting commissural alignment. Before we talked about commissural alignment, there was a significant progression of distal disease. So it's nothing to do with the TAVI valve, it was a distal disease progression. So that's a nice coaxial catheter position. You can see the distal left main. As soon as the catheter was engaged, patient went into second degree heart block. So everything was kept ready in 2 hours. So once you get the catheter in good position, you can do all complex interventions, 2 wires, stenting, because most of the Europeans do clot stenting, not decay crash. So that's what I was used to until I came back to India. Sometimes, even in the experienced hands, when you are doing complex sort of coronary interventions, you forget about this coronary sort of commissural alignment, and that's what happened with this case. 2 senior operators, myself and my colleague, were doing it. In the hurry-burry, we have completely forgotten, and this was about 5 years ago. You can see the C-tab, where the C-tab is. That's where it should not be. The hat marker, sorry, the hat marker is in the inner curve. That's where it should not be. And as soon as it deployed, you can see the open C-tab on this side. It should be this side. And the patient had ST elevation. That is because of the loss of commissural alignment, the right coronary has caused trouble. Unfortunately, because of the experience, we managed to rewire it, one person holding, the other person pushing the wire, and stented mid and stented the ostium. Now coming back to this complexity of the cases, you can do, that's an 8 French guide, you can do complex interventions, even up to 10 French through this. That's a bifurcation stenting with IVL. I'll just skip for the purpose of the time. Both electrophysiology done and double Chris. So I'll stop there for the purpose of the time so that we'll have some discussion. Can we escape that and go to the last slide, please? Here it's frozen. Escape and go to the last slide. Shall I do it here? Yeah. The screen is frozen. Yeah, that's fine. So we go to the last slide and just one before that. Put one before that and go to slideshow, please. The slide before that. It's okay, I'll do it here. Yeah. So those are the steps. So do iotogram, select the catheter, 0.5 less if needed, approach in a coaxial cell. Once you approach it, if there is difficulty engaging, put the wire first, over the wire, railroad a guide extension, over that take the guide in. And then the way you went in after the procedure, come back the same way, don't pull it out and disengage safely. And most of this can be done. If you had a good commissural alignment, 80% of the cases can be done successfully. Thank you. And have a good heart team. With a good heart team, you will always have a good outcome. So it's a surgeon, cardiologist, interventionist, everybody that's smart in Leon sports. Thank you very much.
So you will never use M+ left?
Usually not necessary, sir, because we are not looking for support here. We want to get through the cells. And most of the time you will get a good support because it's a short base frame. So even extra backup very rarely we use nowadays. So Jetkins is more than enough.
This case was in the first session and discussions are there. I think they are likely to participate in the discussion. First session discussion.
Thank you very much.
There was a trial called Re-Access trial where post-TAVI there will coronary interventions, and in 22 failure cases, 21 were from self-expanding core valve platform. So do you feel this cuspal alignment will change the scenario? Do we have a kind of any evidence after that?
Yes, I think this was before the times of we were doing routine commissural alignment. So there are two techniques. One is the cuspal overlap and the second one is the commissural alignment. The cuspal overlap is you are isolating the non-coronary cusp and overlapping the left and right cusp. That is purely for the depth of the implant to get the pacemaker rates down, to get the depth around 2 to 3 millimeters. So you go to the cuspal overlap view, you deploy the first 2/3, then you go to your normal view and deploy the last 1/3. The commissural alignment, once you get the commissural alignment, the reaccessing the coronaries more than 80% of the time, it will not be difficult. There will be specific cases where it will be difficult even with self-expanding as well as balloon expanding. Because if the coronary is too low and if your balloon expanding height is too high, in that cases also you'll have difficult. Self-expanding is the same thing. So as long as you adapt all the techniques, I think nowadays it's very, very rare that we don't access the coronaries.
So thanks for the wonderful presentation. So we have some change in the schedule.
I think if you are asked to choose one valve for the best cell diameter, this Accurate Neo has got the best cell diameter for the sinus axis. What's your view on the choice of valve as far as the cell is concerned in front of the mouth of the left main? And second, the chance of stent thrombus is much higher having a valve first, then angioplasty later on. So how long you continue DAPT? Is it same or is it different?
Yeah, two fantastic questions. One is about the selection of valve and the second is about the coronary as well as the valve. First question about the selection of valve, now it's become about the patient. How long is the patient going to live? If you are having a patient who is 75, you are expecting the life expectancy is going to be another 8 to 10 years, all the valves are fine. Because whatever valve you put in, that will outlive the patient. In that particular patient, I will select based on which one will going to give me the least complications on that particular day. So that means the sinus size, the calcium in the sinus, calcium in the alveoli, coronary height, all the associated features. So in that particular case, if the coronary height is low, sinuses are wide, I will use the balloon expanding. There is no issue with that, and the calcium is less. If the sinuses are low, narrow, coronary is low, I will use accurate neo. If all those parameters are good, I will use the valve that I'm very comfortable with, which is Medtronic evolute, because 80% of the valves I put in is evolute. The important thing is the complex the case you get, use the valve you are very familiar with. Don't try a new valve in a very complex patient. That's the first thing. Coming back to the question about if you are putting a valve in a 65 to 70, where the patient is going to live for 20 years plus, then it becomes a question about TAVI versus SAVR. You have decided it is TAVI. Then it becomes a question about the anatomy. What anatomy is that? Is that going to take in a balloon expandable, like less calcium, not a bicuspid, and quite acceptable? In that case, I will put a balloon expandable first, because it will give me a chance of putting a TAV and TAV later on. I will put a self-expandable in the balloon expandable very comfortably later on. But if the anatomy is not good enough for a balloon expandable in that patient, I will not squeeze in a balloon expandable. A small annulus, because of the patient 65, 68, I do not want to select the first valve as a balloon expandable in that particular case, because put a small valve, like a 20 millimeter with an annulus with a patient process mismatch, and if you get some kind of parallel like other things, that valve is going to degenerate first. So now everything is become as like a life expectancy of the patient and the anatomy, have a suitable anatomy or not, and the valve choice. The last question about your accurate neo. Accurate neo is good for the coronary access. Where I have difficulty is more than moderate calcium. If you have more than moderate calcium, the most radial strength in the self-expanding is with the Medtronic evolute. All the others, Portico and accurate neo, they don't. Coronaries, always TAVI first, unless there is angina or acute coronary, TAVI first.
Thank you. So we have some change in the schedule because of the flight schedules. We have to accommodate the speakers. May I invite Dr. Ranjan Shetty for his presentation. So we have to slightly switch gears from TAVI to left atrial appendage. Dr. Shetty.
Thank you, and it's been wonderful to be here and the weather also is very beautiful. Good to see a lot of familiar faces. I'll be quick, and thank you for accommodating me on in this session. So I'm going to talk about a little bit about LA closure tips and tricks. So this is these are very common cases. We do have a lot of patients with AF. Some of them have absolute or relative contraindication for anticoagulation. Some have had bleeding, like this patient with history of recurrent pre-syncope. Some of them actually are not able to tolerate it, and many of our patients are not on optimal anticoagulation. So I'll come back to the case again just to understand. AF is extremely common, and it's probably one of the most common cause of stroke in elderly, especially people above 80 years. It starts quite early, and if you follow the patients with stroke, you realize that majority of them actually have AF. If you follow them for 5 years, 57% of stroke patients actually have AF, and they are not on very optimal treatment. The optimal treatment, obviously the first line and probably what is needed by majority of the country is anticoagulation. So we use CHADVAS2 score, we use Haspelet score, but unfortunately, they match. The very patient who is at very risk of clotting is also at risk of bleeding. So because of this, majority of our patients both in India and worldwide do not receive anticoagulation. Now, so these are the challenges. Warf has its own challenges. The newer drugs also have their challenges. Now they have been there for a decade. Cost may not be a major constraint now because there are multiple cheaper generic options available, but still compliance is an issue. Even in the best of the trials like Rocket AF and other trials, you realize that up to 1/4 of the patient actually don't take these drugs, even in trial. So in real life, this is much lesser. So what is the alternative? So it's believed that when you talk about non-valvular AF, that means which AF not due to prostatic valve or not due to severe MS or moderate MS. Anything other than that is considered non-valvular. That means if you have mitral regurgitation, if you have aortic stenosis AF, or if you have HCM AF or traditional, they are all considered non-valvular AF. In this, the majority clot, according to very initial studies itself, show that more than 90% of the clot is actually in the appendage. And if you can safely close it and exclude from circulation, you could reduce the risk of stroke by 90 to 95%. So that's the logic which is and the rationale for LAA closure. And then the trials, the Protect AF, Prevail and the Evolution Registry, all of them actually showed us that the logic works in the sense, if you use these devices as an alternative to anticoagulation, even in then, most of the time it is not, it's non-inferior to anticoagulation. But world over, indication keeps varying. Most people receive it when they have bled, and not many trials are actually there in this subgroup. So they tend to receive when they are bled as an alternative. That is only 1% of patients receive as alternative, but majority of the trials are actually in that subgroup. So let's not go into this category. Let's stick to the procedural tips and tricks. The first thing is the LA appendage itself is very unique. We tend to name it as cactus, cauliflower, chicken wing, depending on multiple things, but it's extremely unique as your fingerprint. So no two patients will have exactly same left atrial appendage. So we need to be a little agnostic of this. Whatever you find here, that's not that important. Luckily for us now, whatever device you have in shelf, you don't need multiple devices. If you have any particular device on your shelf, 98.5% of left atrial appendage can be closed with whatever device. And there are some devices which are even better. They can actually close up to 99.5%. That means you don't have to do too much pre-planning. You don't have to inform 2-3 companies here. You may not need a CT scan before you start LA closure. Whatever device, we may be able to close most of them. Now the key thing is there are basically two types of device which are available. One is so-called body-centric, one where you cover predominantly the body like Watchman or Watchman Flex, and second is the neck-centric device. They have two parts. They have they have thing which holds the appendage. They also have a disc which covers it. So lamprey, amulet come in this anatomy. So this is how left atrial appendage looks, and it is very imaging is extremely important. It is always 2% job. You need to have a good echocardiographer who can tell you, and based on that, taking circumflex as marker, you do certain measurement. Now this measurement also varies on the device. Same appendage, if you're using a Watchman, the number is different, and if you're using ACP or lamprey, the number again is different, because depends on where you are likely to land the device. So you have to have a basic idea how your device is going to occlude the appendage. You need to image in multiple views, and once you do that, you need to upsize the device. So typically it looks like this. So if you're using something like lamprey or amulet, you do the measurement which is shown here. You do it in 0 degree, 45 degree, 90 degree, 135 degree. 135 is sometimes difficult to get, but you need to image in all the views. Upsize the device by around between 3 to 4 millimeter depending on the make of device. Too much upsize also doesn't work because there's only so much space which appendage can accommodate. So right upsize is what you need, and then you close the appendage. So next I will just go to the little bit about the step-by-step case presentation. So this is how it looks. So we need echo as we discussed, and the first upper figure actually shows the bicaval view, because that's the important view for septal puncture. So there are basically two steps: septal puncture and device deployment. So these are the two things we have to do. Now septal puncture has to be done posterior-inferior, lower the better, but it should still be in the thin part of the septum. So if you see this bicaval view, you can see SVC here, you can see IVC here. So you would want to puncture here, lower part of the thin septum. You don't want it to be in a thick septum. And next what you do is you ask your echocardiographer to show aortic view, and you want to be away from aorta. So inferior in a bicaval view, posterior in aortic view. To do that, you need to rotate your broken barrow needle clockwise. So typically puncture is only local anesthesia. There is only venous puncture. Half the heparin is given before the procedure. You don't do, although most Indians have good experience of doing a BMV, but this is little different. We need to be able to do the puncture, septal puncture under echo guidance. So once we do that, we are in LA. At this point, we measure the LA pressure. If the LA pressure is too low, because LA is a very thin structure, we need to make sure, it's volume dependent. So if it's too small, we may have to hydrate, keep a pressure of more than 10. Rest of the heparin is given at this point. Next is exchange of catheter and imaging left atrial appendage. So you image left atrial appendage, you measure the measurement somewhere here, and choose the device by upsizing by 2 to 3 millimeter. So once we are in LA, we exchange the catheter. Depending on the device, this catheter is different from the septal puncture. Septal puncture is 7 or 8 French. You try to exchange it in the pulmonary vein, and the neck sheath could be 10 to 14 French depending on the map. I think we'll stick to Lambre. Lambre is around 10 French here. And then what we do at this point is again, just to show the importance of imaging. Here we were in the upper pulmonary vein and we brought it down. As we brought it down, you realize that we have made a bulb here. This bulb of device is actually beautifully seen at this position. You can see where it is, and at this point what we do is we try to do a lot of anti-clockwise turn, because you want to position it up. So two things we should remember: septal puncture is clockwise to go away from aorta. As you are deploying device, as much anti-clockwise, so that the whole axis becomes upward, and you start unsheathing at this point. You start pulling the sheath back with anti-clockwise. You realize that your device is now actually opening up. From a bulb it forms a triangle, and from triangle it starts opening up, and you see the lobule which is open now, and you do the further unsheathing with a little pressure, and the disc opens, and you are able to see all this in echo 2. You know exactly where here you want to be around, you want the lobule to be within appendage most of the time, within circumflex, and you're starting unsheathing, and this is how it works. Once you're confident that your position is fine, it's a pull, it's not really, it's just a wiggle to show that it is stable, or the device is only moving with appendage. And once you're confident of your position of the device, good separation, this is actually an amulet which is deployed here, and we start releasing the device. And this is how it looks in the echo once you do. The device, the lobule is within the red flow is of the left upper pulmonary vein. The device is positioned here exactly where we want. The disc is covering the in LA ostium, and when it endothelizes, which is likely to happen in 4 to 6 weeks, the whole appendage gets excluded from circulation. So, thank you. Like any other procedure, there would be some complication, predominantly pericardial effusion. So you have to be a little careful, be very delicate in the appendage, do minimum movement there, and the puncture is only venous, so the hematoma risk is minimal. Yeah. Thank you.
So, may I ask a question? Like we have done around 22, 23 cases, and amongst these 23 cases, we have found 4 cases of pericardial effusion next day. One we had to drain in the night, and 3 it was self-limiting, and effusion gradually came down. So it's maybe around 10 to 11% P when I calculate with 22 cases, 3-4 cases. So is it the same experience with you? Does it depends on the kind of devices which we use?
Yeah, understood. I think it's a very good question. Right now, my pericardial effusion is less than 1%. The reason being that I am hardly there in appendage. So all exchanges try to do it in the upper pulmonary vein. It takes some time. After the septal puncture, enter the upper pulmonary vein, take a MPA, the bronchus, the middle point of the bronchus is where it is, exchange there. And then when you come, be minimally in appendage. Like as you see, be in LA, slowly enter. You don't have to go till the end of the device, anti-clockwise. Being very, very delicate, respecting appendage is needed. But you are absolutely right. That's going to be the major complication. So you have to be looking out for that all the time.
Amulet has got little better, higher chances of effusion?
I think the highest will be with Watchman because you start very distally. With Amulet, Lambre and ACP, it's lesser, but I think more important is be away from appendage, only be there when you are closing it.
Does size matter about the effusion? Size is bigger, the chance of...
Yeah, it depends on the size is appropriate for this. So when you take Watchman, sir, it's always upsized. Like you want to put 24, you'll put 27, bigger ones you take, but effusion doesn't come because of that. It's more about if you have reached the wall of, it's very thin at that point, and some of the devices have hooks which may be dangerous. I think it's about not, be little away, go very slow, don't do too much pull and push. That's the way it is.
So are you using the pigtail in all the cases?
So it depends on the device which we take. So if it is Amulet, Amulet, you don't need the pigtail at all. All you need to do is make a gola which you saw around and then go in. But if it is a Watchman, pigtail is a must. Lambre has 2 ways of deploying. So most of the time I do take pigtail. So the rule is do not be, your sheath is the worst. The delivery sheath is the worst for left atrial appendage. Do not allow it to be free in left atrial appendage. Always allow pigtail to lead it. And as much as possible, I don't leave my wire in left atrial appendage. I try to exchange in pulmonary vein as much as possible.
So you release the disc in the pulmonary vein and then you pull it
Yes, put in the pulmonary vein. Then on that wire, put take a sheath. Now take a pigtail beyond the sheath. Pull the whole system down. Allow the pigtail to go to appendage and then push the delivery sheath inside the appendage. Allow pigtail to lead every step.
Very rare rare complication, procedural complication, migration of the device from appendage to left atrium. How will you predict the risk factor? How will you prevent it?
Yes, sir. This is fortunately a rare. It's the most scared complication because all of us first think of this complication. Fortunately, it is 1 in 200, so 0.5%. When you are careful, in the sense, it's like any ASD embolization. If you have pulled, seen that the tug, you have to give a tug, wait for some time, it is easy. All these devices like Lambre, ACP, Amulet are easy to snare if you need it. Watchman is the toughest to snare, but luckily embolization is least with that.
Ranjan, that's a fantastic presentation, as always. Now, 2 questions. One is, if you are using a Watchman versus the newer devices with a lobe and a disc, the anticoagulation, when do you stop them? Immediately or after sort of 6 to 8 weeks? And the second thing is, in your experience, between the CT and the transesophageal echo, with increasing the LA pressure more than 10, how often do you have to change the size?
Yeah. So I think it's a good question, sir. Anticoagulation post is very, it depends on the indication. There are patients who just don't tolerate anticoagulation and we don't give them. So currently what we are following is almost all patients are on dual antiplatelet, 45 days post-procedure and single antiplatelet after that. Whether they are on Watchman or whether they are on any of these devices. Only initial trial, the US trials where it was used as an alternative, they did give for 45 days anticoagulation. So we don't do it. And evolution registry actually 60 to 70% patients were only on dual antiplatelet and 4% were not even on aspirin, because this is a real life indication. The what was that size? CT versus, yes. So I think CT I don't do at all. Most of the time we do only TE. See, the problem with CT is they're likely to be dehydrated because it's an outpatient procedure. So the size what you get in appendage is not reliable. What we do on table, there are cases where the pressure doesn't come about 10. You know, you're pumping fluid, but the pressure remains 7 and 8. I upsize the device little. I just take the neck size in my mind, you know, and use it. They are more forgiving nowadays, the device, but like any other procedure, I think there is a learning curve, and first 10 cases maybe we have to be a little careful. After that, it's okay.
Thank you. Yeah, thank you so much. I think in the interest of time, we have to move on. Yes. So may I invite Dr. Anmol Sunamani for the next lecture. Thanks again. A big round of applause.
I think good morning. Thank you, Dr. Dilip, and thank you everyone for having me here and giving me this opportunity. I'm going to talk today on a very interesting topic which is very important to all India, because the patient, the subgroup what is I'm going to talk is 40% of our patient what we treat. So towering bicuspid aortic valve, have we found any difference? About bicuspid valve, what we know about it. The conflicting reports of efficacy, no randomized data yet, still some uncertainty with procedural conduct, little hesitation about treating high and intermediate risk bicuspid patients. Surgery, yes, surgery still have a role in very young patients, root enlargement, mechanical valves, patient with significant aortopathy, hostile LVOT calcium and anatomy, and unicuspid valves. The concerns with bicuspid aortic valves are they are large annulus, eccentric, elliptical, sealing zone, sometimes it is annular, sometimes it is supraannular, positioning, whether we have to place it at annulus, supraannular, severity of bicuspid, whether it is a type 0, type 1 with calcified raphe, non-calcified raphe, asymmetric cusp, coronary occlusions in spite of high takeoff of coronaries, heavily calcified leaflet, and calcification of LVOT and associated aortopathy. Everyone should know this classification very clearly before addressing this patient of tower. It is very simple: type 0, no raphe; type 1, 1 raphe; type 2, 2 raphe. It has been subclassified again, the type 1, into depending on which raphe has been fused. Type 1A, 1B, 1C. LR fusion is the most common. If you see the anatomical consideration, it is a heterogeneous cusp, sinus morphology, heavily asymmetric calcium, long commissural distance, aortic root, aortopathy, coarctation associated with. But important thing is, the bicuspid aortic valve has been excluded from all the RCTs, whether it is a TAVI or whether it is a surgical aortic valve registry or a randomized control trial. So we are just contemplating the same data of tricuspid on bicuspids so far. Sizing we all know. Depending on almost 88 to 90% of the patient, it is sized as per the annulus. Only if it is a tapered anatomy, then we size as per the intercommissural distance. There is another method for sizing, circle method, where you can put a virtual valve and see how the annular, each and every annular root complex behaves with this valve. What evidence says? The paper has been published. It is again an retrospective analysis in March 16. They compared 546 patients after propensity score matching with bicuspid and tricuspid. It shows the aortic root rupture, second valve implantation, paravalvular leak were significantly higher in bicuspid aortic valve towers compared to tricuspid aortic valve. Even a new pacemaker were numerically significantly higher compared to tricuspid aortic valve towers. This is with earlier generation. If you see the success rate in bicuspid, the success rate is only 78% with first generation devices. Even with the new generation devices, the root injury, second valve implantation, paravalvular leak, and they were numerically higher even with the new generation compared to tricuspid aortic valve towers. The all-cause mortality, it shows there is no significant difference, 11.4% and 11.2% between bicuspid and tricuspid. But is it right? Because all bicuspids are not same. Even the STS registry showed the conversion to open surgery, annulus rupture, need for second valve all strokes and new pacemaker were significantly higher in bicuspid aortic valve towers compared to tricuspid. But the limitation of this registry and retrospective analysis, the bicuspid AS represents a heterogeneous anatomic cohort. It is possible that the operator selected the most favorable anatomies and while excluding the patient with high risk anatomical features. Does bicuspid aortic valve morphology play a role in tower outcome? This is very interesting. Dr. Yoon and Makkar has done a very excellent analysis of analyzing this patient and categorizing this patient into a phenotypic classification. They classified this patient into no RAFE, calcified RAFE, non-calcified RAFE, then calcification on the leaflet, more than 300 or 380 or 400 cubic millimeter calcium score, aortopathy, and they compared all these features with first generation and new generation tower devices. So this is a phenotypic classification, no RAFE, non-calcified RAFE and calcified RAFE, and these are associated with the calcium distribution, mild leaflet calcium or excess leaflet calcium. This is very important. If you see 24% of the patient falls into a non-calcified RAFE with mild leaflet calcium, but almost maximum number of patients are heavily calcified leaflet with calcified RAFE. Let's see the outcome. The all-cause mortality is 15.2% in bicuspid aortic valve at 2 years, and cardiovascular deaths in bicuspid are 9%. This is very interesting. I think everyone should give a little more attention. The bicuspid aortic valve with calcified RAFE are having a 20% mortality at 2 years, compared to non-calcified RAFE, which is 11%, and no RAFE, it is 8.5%. Depending on the leaflet calcium, the excess leaflet calcium will have a 2 years mortality is 20%, and compared to mild leaflet calcium, it is 11%. So the excessive leaflet calcium and calcified RAFE, they are independent factors for mortality in patients with bicuspid aortic valve towers. There is another interesting feature. If you see a phenotype of calcified RAFE with excess leaflet calcium, the 2 years mortality in this patient post-tower is as high as 25%. That means every 1 patient out of 4 will not going to make it after 2 years. So we have to be really careful because we are treating almost 40% of the bicuspid anatomies in our countries. Compared to calcified RAFE or excess leaflet calcium, the 2 years mortality is 12% compared to none of them. If you compare a bicuspid aortic valve phenotype and with this calcified RAFE and excessive leaflet calcium, you see the paravalvular leak, aortic root rupture, major vascular complication, and even a 30-day mortality was significantly higher in patient with calcified RAFE with excessive leaflet calcification compared to either calcified RAFE or excess leaflet calcium or none of them. If you see the all-cause mortality in this phenotype with latest generation of tower devices available in the market, even with the latest generation tower devices, the subgroup of calcified RAFE with excess leaflet calcium are having a 2 years mortality of 22%. So it is very high compared to either RAFE or excess leaflet calcium or none, which is 8 and 5%. And if you see, even with the latest devices and the newer devices, the paravalvular leak, aortic root injury, major vascular complication, and 30-day mortality was significantly higher in this subgroup where there is a calcified RAFE and excess leaflet calcium. All-cause mortality and associated and aortopathy, there is no significant difference. So what are the learning points from this phenotypic classification of bicuspid aortic valve? Calcified RAFE and excess leaflet calcification are independently associated with increased procedural complication and 2-year all-cause mortality. High-risk bicuspid aortic phenotype like calcified RAFE and excess leaflet calcium was found in 26%. That means every 1 patient out of 4 is having a calcified RAFE and excess leaflet calcium, and they are associated with 3-fold increase in mortality. The impact of bicuspid aortic valve morphology on outcome was consistent in low surgical risk patient as well as the patient who underwent an TAVR with latest generation devices. What is the clinical implication? The CT assessment of morphology in bicuspid aortic valves is really important to assess the anatomical risk for TAVR in this patient. And in absence of randomized clinical data, treating bicuspid aortic valve, I think CT-based assessment is very important to look for whether these bicuspid aortic valve are suitable for TAVR or not suitable for TAVR. So in order to conclude, not every bicuspid aortic valve is suitable, as we are going to treat 40 to 45% of our patients which are bicuspid, they are young. They are very young. So we have to be really careful before every bicuspid offering them a TAVR. In India, as I said, there are 40 to 45% if you start screening these patients, we treat bicuspid aortic valve. And I must say, I think the dedicated bicuspid aortic valve randomized control trial is in need of time, because we really don't know which valves are really going to do best in this subgroup. Every valve is claiming they are doing best, every valve is showing some data and registries, but I think randomized control trial will answer all the questions. Thank you for your patient hearing.
What about the risk of paravalvular leak in bicuspid aortic valve? Does it depend on the number of raphe or?
Yeah, I think the calcified raphe, excess leaflet calcium, even calcium at the annulus and LVOT, these are the patients who have high risk for having a paravalvular leak, because the sealing usually doesn't happen. It also depends on what device you are selecting. A device with an external skirt will reduce the paravalvular leak incidence as well as the prevalence compared to the devices which don't have an external skirt.
Wonderful presentation. I have two questions for you. One is the aortopathy basically depends on shear wall stress, how much the eccentric jet which is hitting the aorta, bicuspid aortic valve. So what happens, do we have evidence that after the TAVR, this aortopathy future dilatation becomes slow down, number one. And number two, everything in bicuspid aortic valve, calcified valves, the outcome depends on sizing of the valves. If you oversize, it can be catastrophic. And choice of the device. Do you feel Medtronic self-expanding valve is safer because it's a high radial strength, less chances of annular rupture? So these two questions, I think.
Okay, if I understand both the questions, first question being whether the aortopathy keeps progressing or it regresses after TAVR. It is proven and it has been clear, aortopathy does not regress even after surgical aortic valve replacement or TAVR, it keeps on progressing. So any patient with aortopathy, with severe bicuspid aortic valve and severe aortic stenosis, and if he is young, surgery still play a significant role. And about your second question, whether which device? Sizing and which device?
Like annular sizing or supraannular sizing. What about Casper method? Which is the most preferred way of, which way you size it?
I think 80 to 90% of the times the sizing in aortic valve is not different from bicuspid, because it is 80 to 90% of the times it is an annular based sizing, which is the most narrowest portion in the aortic root complex. The sizing differs only in 10% of the patient when there is a taper anatomy, when the intercommissural distance is smaller than the annulus, where we can go with ICD sizing. Rather than only going on the sizing and selecting a valve, now there is one more method called as circle method, in which you can put in choice of valve, the size of valve what you are going to use, put that circle in that anatomy and see how the whole aortic root complex is going to behave with that size what you are selecting. If your valve size is going out of the measurements, then you have to undersize it. If it is completely exactly sealing, then that is the best size. If it is very small, then there will be chances of PVL. So the circle method, I feel, which is more reliable to select. If there is a borderline cases where you can select 23 or 26, you can go with the circle method and see how the root complex is going to behave with that valve size to avoid the complications.
Thank you so much. Questions?
One question, that is, in cases of bicuspid valve, calcification more. And this calcification invade the connective tissue. That is why fascicular block is higher. My question is that if you placement of the our trachea little higher up, that can prevent the complete block after the procedure.
So
there's a report is there. What you believe? Do you believe or not? It will higher up position of the.
See that is, in bicuspid, the coaptation is not exactly at the annular level. The coaptation happens and the narrowest portion happens supraannularly. That is the principle and the concept of come in bicuspid aortic valve. We can start deploying the valve 0 or 1 millimeter or 2 millimeter and higher, because the coaptation will happen and valve will anchor at the narrowest portion. But in bargain to deploy this valve little higher, the pop-out rates, you have to be really careful between deploying it precisely at the higher level as well as valve getting pop-out. So in my opinion, I think the best depth what one should follow for any tower device is 2 to 3 millimeter will be always the depth should be aimed for any tower device, and 3 millimeter depth should not really affect the conduction problem. But aiming for 0, I am not really keen or promoter of a 0 implant or a 1 millimeter implant.
We have only 2 questions now.
Can I have a question to you? Sometimes the bicuspid leaflets are very bulky. In a case of bicuspid aortic valve stenosis with low coronary height, what is your tips and tools?
This is a very important question, because the standard teaching of coronary height of 10 and 12 for tricuspid is not applicable to bicuspid. As you rightly said, bicuspid leaflets are bulky, especially in type 0. The leaflets are huge, bulky, and we have seen a coronary occlusion even with the coronary heights of 14 and 15. So it is important to measure a coronary length, and coronary occlusion is not only the coronary height, it is a complex play between the sinus of valsalva diameter, the leaflet length and the coronary height. So in those kind of subgroups, especially bicuspid type 0, you have to measure each and everything and try to analyze what can be the risk and minimize. If there is a borderline measurements, it is always better to protect the coronaries upfront. Protection will always give you a better chance of saving that patient rather than closure and then approaching that closed coronary to approach and open that later.
Thanks, Dr. Anmol.
Thank you so much.
We have to move on for the next presentation. Dr. Harish, if I can request you. Dr. Mehta had a very bad sore throat and he was advised, rest. But he made it again, with all his, passion to come here. Thanks again.
Yeah, thank you very much. I'm sorry my voice is not the best. So today, thank you Dr. Dilip Kumar to having me here for this structural meeting. It's a very important topic because most of our TAVIs are transfemoral. So we are discussing TAVI in small peripheral accesses. So background, we know TAVI is slowly becoming the standard of care, especially in high risk and almost intermediate risk patients. Is the way to go. Transfemoral is the default strategy. The advantages are we are used to that, short procedure and recovery times. We can do it in conscious sedation, and there are proven improved outcomes with transfemoral. So we started with higher French sizes like 22, 24, and now we have come down to 14, 16. And we used to do surgical cut down, but now with availability of proglides and all, we are getting better and better with our femoral accesses. And this is the recommended sheath size, but we should not get carried away by that, because this is the sheath size before the valve goes in. So the valve expands the sheath, especially the balloon expandable ones. The sheath will get expanded further and you might have to go to 20, 22 French with bigger valves. So we need to know what our femoral sizes are. So if you have a femoral of 5 and 5.5 and you think you can get across with a big valve, you'll have to analyze the CT whether you'll be able to get across with a big valve or not. So many patients in our practice, you will find a lumen less than 5.5. Of course, alternate access is an option, but femoral access remains the preferred choice. Complications, I won't go into it. There can be tons of complications, right from small dissections to perforations and even death due to vascular complications. Who are at more risk? Especially the non-modifiable, shorter frame, ladies, older people, obese, peripheral vascular disease, tortuosity, and blood risk areas. Modifiable ones are how you access, where you puncture, the sheath size. Puncture type is very important so that you do not puncture the posterior wall, especially when you're using the big sheaths, and the anticoagulation regime. So how to combat small femorals? always think femoral first when you're thinking of a TAVI. Access techniques most important, right choice of hardware and valve, keep balloon intravascular lithotripsy assisted with you most of the time. Then you can think of alternate access, how to maintain hemostasis, and early diagnosis and quick management of complications. We won't go into this, we all know how to access the femoral, but the only thing that is TAVI and the bigger devices have made us change, that we have started using ultrasound guided punctures, where you can locate where there is no calcium, you can locate the bifurcation properly, and you can use micropuncture kits to prevent bigger complications. I'll give you a small example of small iliac, which was 4.3. It was 82-year-old female, native aortic tricuspid. This was planned for a 24.5 my valve. And when they sent me the report, I said it can't go through the femoral. But when I analyzed the CT, then you should start looking at calcium distribution and which side is better. And if you see the left side, although the vessels are small, there is no calcium. That means this artery can expand when the sheath goes in. So that's how you decide, so that you see the right is really small, left is also small, but not as small as the right. And this is what you do. So you gradually first dilate that artery with a dilator, which is seen on the left side, and then you take the sheath from the right side very gradually. Never force the sheath really hard. If you force the sheath, you can cause dissections, you can cause perforations, you can lift plaques. Once the python was inside, it was easy deployment. So all peripheral arteries which are less than 5 doesn't mean your valve won't go. So you have to see the CT, see the calcium distribution and decide. Second was, this was 84-year-old female, hypertensive diabetic. Again, very bad femorals. She was chosen for a portico. Why was she chosen for a portico? I'll show you. Because if you see her calcium everywhere, her vessels were between 3.5, 4.5 and more than 270 degrees calcium. But the left looks slightly better, although it was smaller. And portico, because it has one spine and it's very flexible, easily maneuvers that, and we could take it across. You can see the portico very gradually going up. And if you see how bad our femorals are, that when I am with one on the left hand side, I cannot push the pigtail from the right side. So you can imagine how small the abdominal aorta also was. So then I'm marking the NCC with a wire kept inside. There was no way I could keep a pigtail inside. So there was no possibility of the valve and pigtail going through the descending aorta. And we deployed it with that marker, and that was the final result. Of course, now with lithotripsy coming in, when we see patients like these, this is an 85-year-old male borrowed from an international operator. So this was the calcium, this was the distribution. And if you see the angio here, you'll see here there's a huge chunk of calcium at the bifurcation. And the sheath just wouldn't go. If you force this sheath, you're going to dissect or perforate. This was done with a localized IVL of 7 millimeters. And then the valve went across. We had another lady come from Dubai. She had very, very bad femorals, 2.5, 2.8, extremely calcified. And this lady, we realized that, and that time IVL was not available. Then you start looking at other accesses. So we generally use the left subclavian unless we don't have an option. Minimal vessel diameter should be 6 millimeters. And if there are patent grafts, that's very important. Many of them are post-CABG and you still need to use it. Then it should be at least 7 millimeters. An extended calcified artery should be avoided. And this is the puncture point. You have to note this branch here. So you have to puncture in between that zone. If you puncture too medial, you might be entering the thorax. And if you puncture too outside, then you might end up affecting the brachial plexus. The important thing is if you're doing percutaneous punctures of subclavian, your anatomy has to be very good. Otherwise, you can tell your surgeon to give you a cut down. So this is how we analyze it. Again, the same way. See the calcium distribution, how the valve is going to go. Take the stretched view. This is an 81-year-old lady. So what we did, we went from the femoral down, from the small femoral, and we took a shot of this. And then roadmap guided, we did a micropuncture into the axillary subclavian junction, which you can see on the right side. And after that, we deployed 2 proglides as we do for all patients. and we did the valve as we do for every patient. This was the end result. And then you do a balloon tamponade. So you take a balloon from the femoral, tamponade it when you're closing the subclavian, because it is difficult to compress a subclavian. So this is a dry closure. So you balloon tamponade and you deploy the proglides, as you can see. And then we noticed a dissection and we covered it with a covered stent. In subclavian, don't try regular stents, they're too fragile. If you're not covering major branches, that's why puncture site is important. We just go and deploy a covered stent, that was the end result, and that's how we got out of this case. Similarly, you can use the transcarotids, which is the easiest if your carotids are good. The important thing to remember is please assess the circle of Willis. So do not do a transcarotid unless you've assessed the circle of Willis. This is how we do the transcarotid, left or right. Left is a straight shot generally. Be careful because it's very close to the nerve structures. And also remember that if you are not confident, I would not do a percutaneous the first time. I would call the surgeon, let them expose the carotid. It's much easy for them and they're used to that. Transaortic is very rarely used unless it's in the OT and you realize that you can't do. Then the surgeon may call you and say, let's do a transaortic or direct aortic approach. Of course, transapical has almost been given up completely. Transcable also is being given up with lithotripsy coming up, but that's a good alternative. If you have a better abdominal aorta than the femoral, you can go from the vein into the aorta and then finally close it with an ADO device or a Amplatzer PD occluder. And now coming to future, what future holds for us? You must have read about Dr. Aberhard Grube did the first 12 French TAVI for investigational purposes. So we're coming to ultra low profile 12 French delivery system. It's going to reduce paravalvular leak. It has two frames to it. So lower the thing, there's a frame, there's an assembled device, that's how it looks. I'm just going to run through a short video of this, how it is done. So first they deploy the annular frame and then the valve opens over it. And then the valve comes in from top. So that's deployed in two parts. So prevention is better than cure. Vascular access complications have major impact on our outcomes after TAVR. CT is the most important. I definitely believe that all of us have to learn and sit with our radiology colleagues to assess the CT ourselves. Then only we will be able to assess what we can take and what we cannot take and how do we go about it. It's vital for access site analysis, vessel diameters, calcification patterns, tortuosity. I would say have a measurement less than what you feel it is. So if you feel it's 6, take it and trackability of the device you are going to use. So if you have small femorals, I would go with a Navitor or something like that in case you don't want to use alternate access. So most predictable, but complications can come announced. Be prepared. Thank you.
Wonderful, wonderful talk. I think that is the crux. We recently did a case with a 4.8 millimeter average diameter of CFA, and there was no calcium. So that made us do that case. Otherwise, if there is a calcium, it's really sometimes difficult to negotiate and complications are very high. So any other comments? So thanks again, and if there are no comments, we can conclude the session. Thanks to our chairperson's discussions, and we'll go through the third session.
Thank you so much. End of this session. We are moving forward to the third session. I would like to invite the coordinator of the session, Dr. Ashit Khanna. Big round of applause, please. Also, I would like to invite on the dais the chairperson of this particular session, Dr. Rishi Sethi, Dr. Robin Chakraborty, Dr. Shuni Banerjee, Dr. Joyanto Shaha. Requesting all the chairpersons to kindly come on the dais. Also, I would like to request the discussants of this particular session to please kindly come on the dais. Dr. Raja Nag, Dr. Arindam Pandey, Dr. Abhishek Roy, and Dr. Shopon Haldar. Thank you so much.
May I request Dr. Amit Kumar Sharma to be there on dais. Dr. Amit Chorashia was, his tickets were made, and last moment he had some emergency meeting there, so he will be online presenting, and we'll also have a live inbox from Medica where he will be also interacting with us. So Dr. Amit. Yeah, you can go ahead with your presentation, Dr. Amit.
can't hear him.
No.
We can't hear you, Dr. Amit.
Am I audible?
Okay.
Who's supposed to present, sir?
Dr. Amit
Am I audible?
Amit Chorashi.
Okay, oh.
Am I audible?
Yeah, very much.
Okay. I'm really, at the outset, I would like to say that I'm really sorry I could not be presenting in person over there because of certain, you can say, institutional requirement over here. But I'll be giving this talk online. At the outset, I would like to thank Dr. Dilip and the whole organizers for giving me the this opportunity for presenting the case. And this is a very important topic, and we all know valve has now become the standard of care. And it's like an easy job to do in a difficult case. So let me just go through the slides. We all know that a lot of aortic valve cases have been done surgically until now. There have been almost like 450,000 implantation in the past 10 years. The percentage has been increasing. And if I have to say that in the age group of 60, most of the patient ends up with the ones that can be treated with a TAVI device in elegant manner. Now, if you see all prosthetic, bioprosthetic valve, basically they are tissue valve, and all tissue fails over a period of time. And the usual data that they say, the surgeons will tell that the valve lasts for 15 to 25 years, but in real life practice, we have not seen this valve lasting 15 years. Usual time period is something like 10 to 15 years. Are based this record. So we have a number of valves, as you can see in the slide, and this tissue valve can either be extended, have a stem, or
We can't hear you. I think we have lost the link with Dr. Amit Chaurasia. So basically, can we have the link back, please? Dr. Chaurasia, can you hear us?
I can hear you.
But we can't hear. Now you're good. Please go ahead.
Okay. So all transcatheter valves are tissue valves, and catheter valves are, I have to say, catheter valve.
Dr. Amit, if you can switch off your video, I think maybe the transmission is not good. You can get more bandwidth.
Yes, you can turn off your video so we can watch you and listen to you. Watch your slides and listen to you.
What I will do is so that
yeah.
Better?
No, you're coming in bits and pieces, so please try to see if your link is working or your Wi-Fi is working properly.
So what we do is we can start our live inbox, Dr. Amit. We will discuss here, and once your problem is solved, then we'll have your presentation. Okay.
Great. That will be.
Hello everyone, I am Dr. Dilip Kumar, Director of Cath at Medica.
May I request Dr.
We are from Medica. We welcome you all.
And Dr.
Amit Chaurasia is there.
Come on dais and
you
we'll
all
discuss
know
a case
him.
of.
And
Just hold on.
we'll discuss this live in box, and many points will be there, and we'll have opinions from the leaders. Yeah. Can I have the control of the video?
Hello everyone, I am Dr. Dilip Kumar, Director of Cath at Medica, and we are from Medica. We welcome you all, and Dr. Amit Chaurasia is there. You all know him, and we have taken this case for tower as live in box. So this is a case with small peripheral access. She is a 58-year-old female. She has a shortness of breath and diagnosed case of bicuspid aortic valve, and symptoms have been worsening for last 2 months. And the gradient across aortic valve is 84/56 peak by mean. She was counseled for surgical aortic valve, but the patient relentlessly refused that. She only came for tower from different state. So with this pretext, we'll go ahead with the CT finding. So you can appreciate here the perimeter derived annulus is around 19.7, and the coronary heights are good. 12.7 in the left and more than 13 in the right. The problem, the angle is also favorable, but it is a bicuspid aortic valve with mild to moderate calcium. Calcium is a bit into annulus, but it's a very thin rim of calcium, and it's not a chunky calcium, and it's it's at the cusp level and little at the annulus and minor part in the LVOT. So calcium is not a big concern here. Coming to peripherals, sinus of Valsalva is roomy, and it's around 26.1. So if we are going to get 23 valve with coronary heights and this sinus, it should not pose a problem. And LVOT, you see a small calcium there, which should not pose problem. So and coronary heights are okay. So this is the peripherals with a higher bifurcation, and the mean size of the both side CFA is something around 4.7 to 5.2. 4.9 is mean, and in the left and right is around 4.7. So with this access, we are set to do. Obviously, this patient is a bicuspid aortic valve with a young age, trying to go for a TAVR only. So we have chosen a self-expanding valve. should not pose a problem.
This valve will open well. That's my first thing. Second thing, calcium wise, there is some minimal calcium there. It is not going to give trouble in terms of annular rupture or paravalvular leak. So now comes to the sizing, obviously the valve selection and sizing. Because it's a small, perimeter is 60 and valve area is 275. If I have to put a self-expanding, I can easily put a 23 evolutor. If I put a balloon, whichever valve you select, Edwards or my valve, whatever it is, squeezing in more than a 20, it's going to be very difficult. So the body surface area becomes issue. If there is a small, thin, frail lady, I can still put a balloon expandable without patient process mismatch. It's a normal sized patient, body surface area around 1.7, then definitely my choice will be a self-expanding here, a 23 evolute. Pro versus or cost is not issue, and obviously calcium is less. I think Pro Plus gives you that additional seal and you will not have any para, because we want the best result for this patient because young, even the mildest of the paravalvular leak, you don't want it. So yes, Pro Plus was the best choice. 23 Pro Plus, because it will take away the paravalvular leak, it will give a good sealing, and our results will be surgical right results. And access, I think both balloon and self would be fine, because looking at the access, it looks around 6 millimeters, 5.56. So looking at everything, my choice, obviously 23 Pro Plus, we will get a surgical right result. Ravinder?
You know, majority of points I would agree, but you'll have to convince this patient for surgery again after 8 years. So
yeah, I think
it's
this was
very difficult situation. 58 plus 8 is only 66 years of age. Now, if you have to do a TAVI and TAVI again, it's a very challenging situation. You're putting a valve which is across the coronary arteries. You put one more valve inside it. Again, it's going to be challenging. 8 years down the lane, she'll be 72. So it's a very difficult situation. This is a case which we call it as high-risk TAVI. Why it is high-risk TAVI? Small peripheral vessels, bicuspid aortic anatomy, small annulus, patient process mismatch. This is an ideal case which is high risk for TAVI but low risk for surgery. But let's go ahead and decide, now that this patient has chosen TAVI, we also have to think how will we manage the valve degeneration after 8 years. Looking at the present scenario, we have to choose an Evolute Pro Plus 23 millimeter to give better effective orifice area, hoping this patient follows the Notion trial and the valve lasts for 10 years. When she is 70, you put one more valve in valve. But the way you have to put this valve, this has to be with commissural and coronary alignment, so the coronary access and a redo TAVR is more easier.
Yeah, perfect. Perfect.
One additional point is, I will put this valve a little bit deeper, because bicuspids we tend to go 0 to 1, but I'm thinking about my next TAVI in TAVI. I will put this valve around 3 to 5 millimeters deeper. Rather than going for the usual 0 to 1, I'll put the valve deeper so that the future balloon expandable in this self-expandable will be made easier.
Yeah. So you can forward it a bit. Yeah. So okay, you can go ahead. You can forward the because we have 15 minutes to discuss only, and it's a 22 minutes video. We have to forward it. And where's the sound? The measurement which is dilated here, the measurement is 39. Forward.
Basically, we
forward
have
it,
is because that doesn't get easy. Can you heavy duty in these cases? As you can always the same thing will calculate then try out how and so
it's important to
next reach. It's very
forward a bit more.
Prolapsed.
Yeah, go back.
Because
so here,
length
just go
which
back a bit,
you see here
3-4 minutes.
here
So this was the first time when we tried to negotiate the angle, aortic angle, which was 60 degree on CT. It was not the same which we found there. It was quite horizontal aorta. Go a little backwards. and
that one to the LV.
show us where we were trying to
This is perfect. This is perfect.
negotiate the the valve. Before that,
Go down.
This is
Okay.
go back a bit. Yes, yes, stop it. Yeah, continue with this. Yeah. So here we, after the pre-dilatation, we were going in, and I can appreciate the type of the horizontality of aorta, and it just popped up. The entire thing came out. So can we discuss a bit about that?
I think this is predictable because
we had taken a Lenderquist wire because the aorta was dilated to have a proper negotiation.
So we go back again. 90% of the TAVI procedure is done outside the cath lab.
Yeah.
That is the CT assessment and the cath lab sort of before entering the cath lab. This is a RCC NCC fusion. So the way it's going to cross, even if the CT shows its 60-degree horizontality, once you get the wire in, it will become more than 80 to 90 degrees. That's kind of repeated things we see. And when you cross it with the wire itself, it will look more horizontal. When you take a self-expanding, invariably it will look like almost it's more than 90, and that's how it will look like. So the RCC NCC fusion is a real difficult one. And majority of the time, if there is a calcified raphe, I do tend to keep a snare in position. If this case has to be done, or another sort of technique which you are going to use, be prepared with that. There are multiple techniques which you can use to get the valve into a coaxial position. But this is predictable. And also after getting into crossing the valve, getting the valve to sit down so that you get a 2 to 3 millimeters or 3 millimeters depth on the NCC side and about 4 millimeter on the other side, that's going to be very tricky. We will see that. That's going to be very tricky until you manipulate the wire and have something to center it, and those kind of sort of additional manipulations will be needed. The wire choice, most of the times you can get away with the Confida or Safari. The Lenderquist, where it helps is, one, you have to know how to handle it. Second thing, if you handle it well, keep it nicely in the LV towards the apex, the valve will not move. It will give you a good stability, but you have to be careful.
So here the Lenderquist wire was given extra curve to give more support, so that the floppy part, it gets curved only, and you can take the device on the tougher part. So with this, the valve was crossed, and the Lenderquist wire was parked, and then it crossed well. Sounds?
We are inside, so I just position the wire so that it doesn't damage the LV. And we can see now the wire is in perfect loop.
Now we'll place the pigtail now also, because sometimes the pigtail gets caught there. So I will remove it and place it again. Okay.
Yeah, pull back.
Okay.
Yeah, let's go up.
It's important
again.
step. Which one? Yeah.
Yes, let's come to the deploying angle, please. Yeah, that's perfect.
Go to the cuspal overlap view.
Please, some more.
Or caudal.
Go LAO.
LAO. You see now the parallax is removed.
Okay, perfect.
Yes.
That's it.
Parallax
Ready for one
removed.
injection, please. Inject. I think this is a good position to start with. We can see the pigtail has come slightly above. So when we start at this position, the valve is going to dive in by 3 or 4 millimeter, and it is going to come in the right position. Okay, so I'm starting to open the valve. Inject.
Perfect.
Okay, this looks a good position, but I would like to pace at 140, please. Okay, pacing off, please. We can take an injection because I feel the pigtail also has come up. So let the LV recover and dry Cine one. Okay, I think parallax is out almost. So let's take an injection in this position. So Cine, inject. Oh yeah, too deep in. So what we'll do is I'll recapture. So what I basically did is I partially recaptured and redeployed the valve. Inject. We can still, there is a chance of improvement. So let's try one more time. Okay. Again, what I'm going to do is Going to recapture this time completely almost. Don't pull, don't pull, don't pull, don't pull, push in fact. Okay, that's it. So let the LV recover. You can't see the pressure. So this is the usual problem with when there is a small annulus. The valve tends to dive in again and again, and you need to have that right sweet position where the anchoring can take place. Okay, this time I want to pace at 180. Okay, can you pace at 180 please?
It is good.
Okay, can you stop the pacing please? Okay, this looks very good to me. The position as well as everything. So what we are going to do is we'll go to LAO. We are going to take one injection in this view.
Let the LV recover a bit.
The LV is good, I think. We can take. Inject.
Yeah.
Looks good
Yeah.
to me. I don't want to
Perfect,
further
perfect.
improve upon this. This patient already had a RBBB, so we know that this patient is going to have a pacemaker. So even a small depth, if it goes deep in, it's all right. And regarding all the complexity we have, the horizontal aorta, the dilated aorta, the small femorals,
Discussion here,
small annulus.
the deployment
I feel,
process.
that
So we saw the difficulty in small annulus and a dilated aorta, how the valve can go in. So any comments and any tips and tricks here?
Because I use quite a lot of self-expanding. I think 80% of my workhorse is evolute. Only 20% I use the others. And I pre-dilate all bicuspids, irrespective of what I see in the CT. I pre-dilate.
It was pre-dilated as well.
Yeah, to the minimum diameter, so that you don't post-dilate as much. And because this is small annulus, you will tend to have this valve kind of going little bit in. It will try to dive in. But the first sort of deployment works as the pre-dilatation as well. So you tend to go whatever it is, go up to the 2/3, allow it and recapture. Recapturing, I think it's very important we do under controlled pacing, around 130, 140 controlled pacing and recapture, because sometimes these valves can just jump out and dissect the aorta. It's very important. So you do that under controlled pacing. And once you do the partial recapturing, then you can reposition to a stage
slowly
around 0 to 1, it will move down. So you bring it up to 0 to 1, then you go on control pacing.
Some more forward pressure,
you don't need
please.
to go 180, control pacing and start deploying very slowly.
Some more, slightly
and
forward
hold that
pressure.
position. It will move
Some
down
more
and it will
forward
settle down
pressure,
around 3-4
please.
millimeters.
Okay,
Once
now
you deploy
both
2/3
the
in the cuspal overlap
pins
view,
are out.
then you go to the LAO as you
So,
showed there.
can you come to
the LAO
AP,
view, it
please,
will look more
facing off?
shallower. Don't worry about that. Remove the
Just
parallax.
show me,
If your
I
depth
want to
on the
bring
other
out the
side,
nose
your side is
cone.
good,
Yes, the
then
nose
that's the
cone is
place
out
to
now.
deploy the valve.
The only thing is
And that's the usual routine.
I'm
Most places
very,
follow
very
that.
unhappy with
But
the
with
wire.
regards to this
So what
kind
I'll
of
do is
diving in, it's quite common. It's
we need to
but it
take
will
that
happen in the
decision
first
whether we
1 or
want to
2 times
post-dilate or
recapturing. That
not.
also works as a pre-dilatation.
So Lunderquist wire should not come out like that.
Any comments
through
on
valve.
the wire
Sometimes it
tension
can
which when you
catch the
release
valve,
this
isn't it?
and while you take
Yeah,
the valve
that is-
and when the go with the deployment first till you come to third node, how should be the wire, how much to the wire tension, and then when you release it?
The wire manipulation is minimal during the time of the 2/3 deployment. But when you go to the LAO, when you're going to do the final 1/3 deployment, make sure it's not towards the apex. You can bring it towards the mid cavity. Again, control pacing. Again, half a turn sort of every second. Very slow deployment. Allow the valve to expand on its own and fall into position. So final 1/3, because the valve is already working, you can do very, very slow deployment and allow the valve to sit down. Once the valve is fully deployed, make sure that both tabs are off. Sometimes we feel like that it's deployed, but one of the tabs will be still caught. Yesterday's case was like that. You may have to rotate the whole thing to get rid of the tab. 2 orthogonal views, see the tabs are released. Tabs are released, then you bring the wire back, but don't pull all the way into the nose cone. Most of the European and US operators started doing that. They almost bring the wire back. But I tend to bring it just up to the nose cone so that the nose cone centralizes. Then you retrieve the nose cone, then push the wire. Again, most of the Europeans and US people, they started removing the wire as soon as you deploy the valve. I don't think we need to do that. I am not doing it in my practice. I still keep the wire. Then you do the echo and all the other parameters. If you're satisfied, you remove it. Otherwise, you still go post-dilate.
And final comments from for the post-dilatation, the valve looked constrained and the gradient was 9 mean. Can you show, can you go with the last part of the live inbox? If you go for a post-dilatation, how aggressive should we be, and what should be the size of the balloon which we choose and how we choose, that needs to be discussed.
Final.
Change to a pigtail in the LV and the aorta, you see the gradient as well as you see the AR index, and also look at the echo.
This is a 9 mean gradient. So do you go for post-dilatation?
In this case, I will post-dilate because around mean of 10, we don't want to leave it in the table because there is still optimization because this is an young patient. We started with an young patient. If this is an 85-year-old or something, you are doing as a procedure that is different. In a 58-year-old, you want to have a surgical-like results. So I will post-dilate, and what we need to remember with this evolute valve is each size has a different sort of waist. So the 23 has a 20, and the 26 has got a 22, 29 has got a 23 millimeters. So each one is different, and never exceed that waist size when you are post-dilating. Previously, we used to be aggressive. We were mad. We were putting a 24 or 25 balloon in a 26 valve and post. Nowadays, we don't do that, and the IFU recommendation also don't do that. So maximum for this will be a 22 balloon, not beyond that. You can put a 20 first. This is a 23 valve, no?
23 valve.
23, that means maximum is 20.
Yeah.
So I'll put a 18 or 20, first 18 and then 20, maximum 20.
So we post-dilated it after that, and the hemodynamics were acceptable.
Beautiful curve.
So
yeah,
any
I
other
think
points,
we had challenges at many places. It was a small peripheral access. It was a aortic valve.
Yeah.
There was a calcium which was there, although not very huge amount of calcium.
No, yeah, I will show you my presentation, conduction disorders in TAVI. So this was a very interesting case. She was having a RBV with left posterior fascicular block before we went for TAVI, and we had an idea that we'll go for a pacemaker probably in this case. Next day after the tower, TPI was there, and her ECG was RBV with left enterohemi block. So we're still in confusion what to do, what not to do. We kept the TPI for another 24 hours, we saw, and there was no problem. PR was well within normal limits, so no other changes were there. So then we removed it. We put the patient on patch recording for 7 days after discharging. That too was fine. So it is after maybe 1 month post-TAVI now, she is without a pacemaker and she's doing well. So if there is any last remarks, then otherwise we can go ahead with the next presentation.
That looks a good implant. I think that's what we wanted to have, around 4 to 5 millimeters depth, because we are thinking about the next valve. So even if it's not right bundle otherwise, I would have put it at 4 to 5 millimeters depth so that I can put a balloon expandable in future. Pacemaker wise, I would have put a pacemaker.
You would have done a pacemaker.
I would have put a pacemaker.
Yeah, Harish. Yeah, definitely. Yeah. Pardon?
So one thing is sure that we put a supraannular valve.
Yeah.
Would you choose a different supraannular valve for this patient?
Yeah, I think it is a small peripheral access, and yeah. Any comments?
In case you're forced to do a TAVI, I mean, of course, this is a case for surgery which we discussed. Would you, because that's important, because this is going to keep coming to us. We're going to have patients who are going to come and tell us, you know, I want TAVI, I want TAVI. So how do you tell your patient that this is the valve for you, this is not the valve for you? I know it's a difficult thing to say, because many of them come with valve choices also. So how do you all go about it?
So from my side, like Notion trial, there's only one RCT considering the durability of the valve, and that is for with the Medtronic valve. So considering the durability, it suits well. Small peripherals, it suits well. High radial strength, although there was not much of calcium, so we could have chosen another platform also. So I think that was a fair, good choice.
I agree with you, sir. We will be bombarded by the industry with thousands of valves coming in front of us. Now there's one more new valve which is coming out and saying we are the best in the world. But we have to choose the valve which we can do good justice to the patient. All of a sudden new valve comes out and you want to operate, you want to put that valve in a new patient, in a young patient, and valve pops out, it's a big problem. So I would still, in such type of patient, I would still go with the valve which I'm more comfortable. Now, theoretically, you can discuss 1,000 things. Now, there's a valve which is a combination of supraannular and a balloon expandable valve with better coronary access. But as I said, this young patient, 10 years down the lane, she's going to give trouble whatever valve you choose.
You had anything in mind, Dr. Harish Mehta?
No, I think I agree. We have decided self-expandable. That's what you have decided, because I showed in my presentation as well. The most complex the case, the better you use the valve you are used to, because you will get the best result with that valve rather than trying something new for that particular patient, because we wanted the best surgical results in this patient. Any time of the day I would use a Medtronic in that case, because that's what I'm used to. With the theoretical aspects, with kind of supraannularity, otherwise large cells and all the other things, there are valves available which you can use with the large cells. But it's a comfort and what you are used to. But still, if the patient has been counseled, if surgery is still an option, surgery would have been an option.
Yes.
See, the most important thing is in this anatomy, though the patient is young, it is a bicuspid anatomy. Though the other valves might have some advantages, amongst all the self-expandable platform, the platform which has a relatively significant radial strength will be Medtronic. Yes. I think this will be a suitable choice, because in spite of being a Medtronic valve, we have to do a post dilatation. So we have to select the anatomy, we have to consider the anatomy as well before selecting the valves, though there are multiple options available.
So we have taken a lot of time on live in box. Yeah.
I have a feeling that the younger patient bicuspid aortic valve is much more complicated as compared to an elderly 80 years old degenerative valve, and we have to tell them that the complication rate in such cases may be higher as compared to the elderly patients, especially in this case.
So thank you. I think it was a wonderful discussion. And Dr. Amit, are you there?
Yes, I'm there. Can you hear me now?
So we can have your presentation and then, yeah.
Yes. I'm really sorry about last time. So, okay. So, a few of the slides we have already gone through, so I'm just going to skip those slides. We all know that most of the implant these days above 60, it's going to be a bioprosthetic valve, and the last 10 years, it's almost 500,000 patients have received bioprosthetic valve. I'm just going to skip through. Now, all bioprosthetic valve over a period of time is going to fail, because these are tissue valves, and no tissue valve is going to last lifelong until and unless it is going to be some kind of other materials that we are going to use. The best result among the surgical valves has been with Carpenter Edward Perimount valve until now, which has lasted roughly around 10 to 12 years. The surgeons would have told the patient that these valves are going to last for 15 to 20 years, but none of these valves actually last for 10 to 15 years. If you see the tissue valve, these valves can either be a stented valve or it can be a stentless valve. Now, the leaflet can be mounted either externally or it could be mounted internally. And this mounting of the leaflets will have the bearing on the valve procedures that we do in TAVI. All TAVI valves, internally mounted leaflet, they could either be a balloon expandable valve or they could be a self-expandable valve. Regardless of whatever it is today, non-invasive method, that is less invasive method, I would say, would be a better choice for doing any kind of these cases. And in a valve has been standard of care these days. Now, if you see a valve in a valve procedure, in this slide, you can see we have 3 or 4 factors that we need to take care. One is the native sinus that is there. The other one is the new sinus that has been formed by the bioprosthetic valve that is there. The third thing that we need to consider is the coronary height, because that is likely thing that might get closed is the coronary, because if the coronary height is not suitable, then that may pose problem. The fourth thing and the most important thing is the hemodynamics, because these valves now are constrained valve, the surgical valves. We only have that diameter. Now, if we want to increase the diameter, we'll have to cause the rupture of these valves. Now, different kind of valves you can use in doing your valve-in-valve procedures. Again, it could be either self-expandable or a balloon-expandable valve. It could be a supraannular valve or annular valve. And different valves has been tried. But to tell you the fact that nowadays the balloon-expandable valve and the self-expandable valves are the standard of care. If we see the valves, then these valves are made with a stent post, a base ring, and that will give rise to the bioprosthetic valve. Now, there are various diameters that are shown in the valve, but the most important diameter is the internal diameter, because we are going to choose a valve depending on the internal diameter. And you may have different sizes written on the box on the surgical valve, but the internal diameter may differ, and that is why we need to take care of that when we are selecting a valve. And this is what I wanted to show. The internal diameter can be different for different kind of valves. And while you are selecting a valve, that should be in your mind. This is an excellent app by Binny Bapat, and you can actually go through this app and select your valve. He gives all the kind of internal diameter, what valves should be used, and what you are going to select in this kind of if you are doing a case with a valve in a valve. The essential thing is know the pathology. Now, valve failure could be either stenotic or it could be regurgitant. If you have a regurgitant valve failure, then your hemodynamics is going to be excellent. But if you have a stenotic valve in which there is a lot of pannus formation, then the valve area could have decreased. Then you will have to decide whether you want to pre-dilate this valve or not. If you decide to pre-dilate, what should be the balloon size? The second thing is see what kind of surgical valve has been implanted. Now, if the surgical valve implanted is externally mounted leaflet, then the chance of coronary occlusion is going to increase, and you will have to take all these factors into place: the height of the coronary, the sinus of vessel, or what is the diameter. Decide which valve you are going to use, or whether it is going to be a self-expandable valve or a balloon-expandable valve. Now, self-expandable valve with a supraannular, everybody will say that should be the standard of care. But if you have a surgical valve which is already 25 millimeter, the internal diameter is going to be 23. In this case, it has been shown in trials, no matter whatever you are going to use, they are going to give a better hemodynamics. The third thing is, if you want to save the coronaries, what are the things you are going to use? Whether you are going to do a Basilica or you are going to do a chimney procedure, that you need to decide beforehand. And if your hemodynamics is not going to be good, then what you are going to do, whether you want to do a valve fracture or not. Now, patient selection, it should be the key. You need to do T in these patients to see if there is a concomitant PVL or not. If there is a concomitant PVL, then you will either have to give to the surgeon or you will have to close that PVL and do a TAVI in this patient. If the valve has a rocking movement, definitely you are not going to do these cases, because these cases you'll end up embolization with the valve. The second thing is, no matter whatever valves the surgical valve has been used, the CT is the mount in sizing, in coronary height, and deciding the plan. Now, the valve size you can decide depending upon the annulus. There are few key factors that we need to look at. One is the hemodynamics, which is the most important factor, and the effective orifice area, the pressure gradient. Those are the key factors. The second thing is the coronary, whether you are going to close the coronary while doing the TAVI or not, and finally the PVL. Now, the higher the implantation, the best gradients you are going to get. And it's not only with the self-expandable valve, and it can be even with the balloon expandable valve. Now, in this slide, you can see there are three depths of implantation. One is 17% depth, another one is 13% depth, and another one is just 0.4% depth. And you can see with 0.4%, you have the best gradient available to you. Now, on the other hand, if you are going to place the self-expanding valve slightly deep, then that valve, the supraannular valve, is again going to act just like annular valve, and your gradients are going to be high. This cartoon clearly shows that if you even implant a balloon expandable valve, a slightly higher position, you are going to get a better EOA rather than if you implant it slightly deeper. And this has been shown in a number of trials that you keep the deep depth higher, you get a better hemodynamics in both balloon expandable as well as self-expandable valve. Now, if you go through a lot of meta-analysis with the valve in a valve, you'll come to know that two things that make the difference. One is high implantation, and another one is use of self-expandable supraannular valve. And those two things make the best the difference is with the hemodynamics in these two outcomes. Rest doesn't matter. There is another excellent trial, and you can see in this again the hemodynamics is better with a self-expandable valve rather than a balloon expandable valve if it is if you are using a supraannular platform. This slide clearly shows that in this case a supraannular valve has been placed slightly deep in, and if you see in this case the hemodynamics is going to behave just like a annular balloon expandable valve or annular valve that is placed. So you are not gaining any advantage in putting a self-expandable supraannular valve deeper in this case. Probably the operator would have put this deep because he wanted to protect the coronaries. But if you are going to protect the coronaries, you have other method as well. Now coming to the next thing, if you suppose in any case you didn't get the hemodynamics as you wanted, then you can fracture these valves. However, you should keep in mind that there are valves which are fracturable and there are valves which are not fracturable. First, let me show you how we do the valve fracture. So the equipments are fairly clear. You need a non-compliant balloon, you need an inflation device, you need a syringe which is 50 cc at least, you need a stop clock, high pressure stop clock, and then what you need to do is you need to place the balloon at the valve. You need to first go with the syringe, and after we go with the syringe, then what we do is we turn the stop clock towards the inflation device, keep going higher with the inflation device, and at one point you will see that there is a giveaway feeling, and that giveaway feeling indicates that you have ruptured the valve. The question is, when do you rupture? Pre or post? Now, a lot of operators will tell a lot of things. Sushil always fractures the valve, pre, but he is an experienced operator, and he can take the valve up quickly and deploy the valve. But if I have to tell, fracturing post is a wise idea because then you don't have that concern of severe AR developing post fracture and the patient hemodynamics deteriorating. So which are the valves that are non-fracturable? Particularly trifecta and Hancock are the ones that are not fracturable. Now the term modifiable has crept in, and that only means that you can slightly modify these valves. You can see the hemodynamics, so you can get a better hemodynamic post fracture of the valve, and that is the key in hemodynamics. The third thing is the coronary access. Now, a lot of times, the surgeon, what they would have done in order to implant a larger valve, they would have positioned these valves supraannular. Now, when you position a valve supraannular, then the coronaries are going to get affected while we do TAVI. Now, if the coronary height are low, then the chance of coronary occlusion can be there. And it has been seen that externally mounted valve leaflet has more chance of coronary occlusion. Same stentless valve has more chance of coronary occlusion than the stented valves. Also, if your valve to coronary distance is less than 4 millimeter, you have a higher chance of coronary occlusions. And these are the few cases shown where coronary occlusion have occurred. In order to prevent coronary occlusion, you can either put in a chimney-like procedure, or what you can do is a vesicula. Vesicula means basically splitting the leaflet. And when you split the leaflet, you get this amount of orifice through which the coronary flow can be maintained. But you should also keep in mind, while you are splitting the leaflet, where the leaflet split has occurred makes the difference. If you have made it in the medial position, then you get the best coronary flow. But suppose you split the leaflet on the side, then one of the leaflet is again going to be larger than the other leaflet, and the chance of coronary closure can still be there. So with vesicula, still you can have an 80% chance of coronary closure. Now let me just show you a case. This was an 82 years old female, had a mosaic valve, and the valve had degenerated, had severe AS. Now, degeneration was to the extent of forming pannus, and the pannus has formed in such a way that the valve area had decreased to something like 14-15. Now, here you need to decide like whether you want to predilate this valve or not. Most of the time, we fear predilating a valve, a surgical valve, for two reasons. One is you may create excessive ER. The second thing is
Amit,
you may rupture the...
we are little short of time, so if you can quickly...
yeah, I'm just 1 minute and I'll finish up. So the second one is you may create a stroke in this kind of patient. So if you see the coronary height was also slightly low on the left side in this case. VTC was good, so we are not much bothered about the coronary height. We crossed the valve. We decided to slightly predilate the valve with a 16 millimeter balloon. And then when we predilated the valve, it was easy for us to take this valve in. The first time we deployed the valve, it was too high. I was afraid that this valve might just get embolized, so recaptured, repositioned the valve. The second time the valve dived in, probably it was a more stenotic valve, so it was diving in. And the third time we were able to put in a right position, and after that we still had some gradient. So we decided to fracture this valve, and then we decided to go with a balloon. We first inflated the syringe part. Now I'm going with the deflator part, and towards the end you can see that small giveaway still that we get. Yes, here. And that was the time we knew that we had fractured the valve. We got an excellent hemodynamics post-fracturing the valve, and that was it. So most of the things I have already discussed in my presentation. These are the small summary that I can make out. Thank you so much for giving me this opportunity. I still feel for a valve in a degenerated valve, TAVI valve is the key and should be the standard of care in present day world. Thank you so much. Any questions? I'll be happy to answer.
Yeah, fantastic presentation, Dr. Amit. And can we have some comments from panel? Any experience on pre-fracture of the valve before you deploy the valve? You fracture it and then take the valve. Any experience? Because studies have shown that this can be dangerous, and they are saying that should not be done rather.
Obviously, there's goods and bads of both pre and post. That was a very nice presentation, Amit. Nice to see you. In terms of the fracturing, a majority of us now has gone to the stage of putting the valve, especially if you're putting a self-expanding, put the valve first and then fracture it. In terms of the risks of fracturing pre and the associated aortic regurgitation and the concern, I don't think it's a major issue. Obviously, the only issue for me there is pre-dilating and sending those fragments up. In a surgical valve, degenerated, if you are pre-dilating to in view for fracturing, you send a lot of material, so the stroke risk might be sort of increasing. Otherwise, it's much safer. And again, putting a balloon in a newly implanted valve and fracturing, there is enough evidence now to show that we are not causing much damage to the leaflet. That was always a concern. So my practice is valve first, hemodynamics. If hemodynamics is good, I don't fracture it. I might just balloon it for modification. If the hemodynamics is not good, I will fracture and get the optimum.
Thank you. Thank you. Now can I request Dr. Ravinder to give comments on this presentation as well?
One other thing is, I think valve-in-valve using Sentinel more frequently now to avoid any cerebral embolization also, because we don't want the fragments to go up. So valve-in-valve, we are actually now using a lot of Sentinel as a default.
Absolutely, yeah. I think the cerebral protection on its own is a separate topic altogether, but if you have to use cerebral protection, now we don't have any kind of guidings to say this patient you use it, this patient you don't use it. The only guiding thing is cost. If cost is not an issue, use in all of them. That's what at the moment, yeah.
Dr. Amit, request you to stay back there and enjoy the presentations and give your comments as it comes.
Thank you. Thank you. Definitely. Thank you.
Dr. Chodoshi, one question. Why the all complication valve-in-valve is less? Starting from paravalvular leak, as well as the conductive tissue involvement, coronary occlusion, everything complications are less in case of valve-in-valve compared to native valve.
So a valve-in-a-valve procedure time is less. We are not going on pump, number 2. Number 3, if you see through CT, we have already made sure that the coronaries are going to have a good flow. Number 4, hemodynamics is going to be better if you choose the right kind of valve. Number 5, if we talk about conduction defect, I always say that in a valve pacemaker rate is almost nil, because you already have a surgical valve, and that surgical valve frame will prelude your valve not to reach up to the LVOT or up to the membranous septum. So your chance of pacemaker is very, very low in these patients. And if you see, the hemodynamics is the key that is going to matter. As Anant told, that 2 things again, you're fracturing, if you are fracturing pre, the chance of AR and the deterioration of hemodynamics. Number 2, the chance of stroke. And that is why we don't want to predilate all our valve-in-valve procedure. You put in a valve, you send, even if there is a thrombus over there, you may just, gel the thrombus, and that way you can decrease the risk of stroke in these patients. Now, valve deterioration, if you see, it could be because of PANUS. If it is because of AR, it could be either because of infective endocarditis, or it could be because there is a thrombus over there that is causing the valve leaflet, immobility of the valve leaflet. So these are the things that we need to take care in these patients.
Thank you. Thank you, Doctor.
Good afternoon, everyone. Thank you, Dr. Dilip, for inviting me, and congratulations for the great meeting, and also congratulations for the complex TAVR which was done successfully. My topic is TAVR to safe TAVR. How do we move from doing the TAVI to doing it safely and also minimizing the complications? Data from the low-risk Evolute-R and also from the Partner 3 trial clearly shows that the complication rate has come down drastically in the TAVR patients. So there are certain things which we need to take care: vascular complications, stroke, PVL, rupture, perforations, obstruction, embolization, difficult crossing. Okay, let me play this and let me generate some excitement in the room. Can anybody describe the course of that sheath? Anybody? Anyone, any resident in the room? Sir, you are not allowed. Not experts like Dr. Yadav can describe them. Any resident, any DM cardiology, 3rd year or a fresh pass out resident? Anybody wants to raise hands? And just describe the sheath of that, course of that big sheath. All right, sir, then you have to teach us. Rakesh sir, you have to tell us this. Okay, anyone else?
Or it can be kept outside and taken
okay, this is inside the body. Let me give you a hint. Anyone else? Anybody wants to take this? This is a real complication which can happen. Okay, so let me give you a hint. The big sheath is being advanced on a soft wire. Anybody wants to describe the course?
It has gone beyond the vessel, ruptured the vessel.
No, because everybody was getting bored, so I thought we'll have an interesting slide here. Okay, so let's proceed. So sheaths, we know, whenever we talk, we're going to discuss about this in the end. So sheath, we know, everybody talks about 6 French, 7 French, 8 French, and now we have understood that these numbers are basically referring to the outer dimension of the sheath, not the inner dimension of the sheath. So very, very important, it's the OD of the sheath which is interacting with the vessel wall. So we should know how much can we oversize. A vessel can be stretched safely to 1.05 times its diameter. Maybe a non-calcified vessel, maybe 1.15 times its diameter, not more than that. And then we should know how to take a puncture to decrease the vascular complication rate. Majority of us have come down to an ultrasound guided puncture. Very important that we start learning an ultrasound guided puncture to identify the sweet spot on the femoral artery. But this is very important, you advance your big sheath on a stiff wire under a fluoro examination. And this is how we can minimize the vascular complications. How do we prevent? You should have a covered stent always in the room, know the OD of the sheath, but when you are anticipating a perforation, do not remove the sheath completely. And here you can see the sheath and the dilator is on a stiff wire. You see this perforation, you advance the sheath back up on the stiff wire, put a covered stent inside the sheath and take care of the perforations. Then puncture in the SFA can lead to complications. We should be prepared to do a balloon dilatation. So that's very important. We need to minimize the vascular complications, and to do the technique to do this is understand the interaction of the sheath with the vessel diameter and to take the puncture at the right spot. Stroke. How do we know this? We should know what are the predictors of stroke in patients with TAVR, a calcium in the arch, a calcium in the ascending aorta, calcified leaflets, atrial fibrillation, patients with porcelain aorta. And then you choose the valve properly, the valve which can negotiate through such type of calcified vessels. And here you can see a calcified chunk and a valve with sapien 3 which could be flexed across the arch. We should be able to identify patients with LV apical clot. But this is very important. Stroke is going to happen to all of us one of these days. Are we prepared for it? Because we are talking about TAVI to save TAVI. We should be prepared in our cath lab with an intervention neurology backup to take care of the stroke. Here's an example, a patient underwent a TAVR, patient was not moving the one side of the body. We did a cerebral angiogram and aspirated the thrombus, and you can see the the anterior cerebral artery was flowing. So the point which I want to highlight, we have to be prepared for all the complications which can go wrong in the patient. Pacemaker reduction. Now our pacemaker rate has come down to single digits thanks to understanding of the cusp overlap technique which we now use for all patients. Here's an example of an 82-year-old female, sinus rhythm, right bundle branch block. And what is cusp overlap? You overlap the right and the left and keep none on one side. How does it help actually? Does it do anything to the anatomy? No, it just changes the fluoroscopic anatomy, the way we are looking at the LVOT. And the depth, in the LAO view, the depth perception is not accurate. However, in the cusp overlap or the RAO caudal view, you can perceive the depth of the valve implantation more accurately. And here is a valve which is being deployed at 0 depth with rapid releasing and rapid pacing. So I'm not going to discuss those details, but no PVL, no pacemaker rate. Can we use this for balloon expandable? Yes, here's an example of an Edward sapien 3 valve which is in cusp overlap view, rapid pacing, and you can look at the final deployment, 0 depth. So cusp overlap view has actually reduced the pacemaker rate, and I'm going to share our pacemaker rate in our own first 100 cases was just 5.7%, and all patients who got pacemaker rate were like 84-year-old, LBB with first degree, atrial fibrillation, trifascicular AV block, trifascicular AV block, trifascicular AV block. And our pacemaker rate was equal in both self-expandable and balloon expandable. Paravalvular leak, very important to identify the paravalvular leak which is left at the end of the procedure, and we should know our goals, how much of paravalvular leak are we going to accept at the end of the procedure. Here's an example of a bicuspid aortic valve, and you look at the paravalvular leak in this patient. So this patient has significant paravalvular leak, but you need to understand, you can also look at that calcium which is jutting right out of the LVOT and touching the calcium. So choosing the right balloon, and this is how the calcium moves, if you can understand the movement of the calcium. So you need to understand that what paravalvular leak is acceptable to you at the end of the procedure. In the low risk patient, the paravalvular leak should be 0. We did a post dilatation in this patient, taking a chance, and there is no paravalvular leak. Sometimes immediately after the procedure, your patient develops hypotension and you can see pericardial effusion. How many have echo in the cath lab when you are doing a TAVI? So all of us should have an echo machine in the cath lab when we are doing a TAVI. Okay, how many ask your assistant or a junior cardiologist to do echo in the cath lab before starting the procedure? It is very important. The reason is the doctor will be struggling when there is a complication to find the right window. We would always ask our cardiologist, second, third cardiologist to do the echo even before patient is painted and draped. Now he knows that at what place he is going to find the right window. Otherwise you lose time just to find the right window because patient is supine. Causes of LVOT rupture we already discussed, LVOT calcium and annulus rupture. Now we have started using the right wire at the right spot. Very important. Safari wire at a wrong spot will cause free wall rupture. A safari wire in the submitral apparatus is going to cause severe MR and hypotension. You need to have the right wire at the right spot. And how do we position? You can see a horizontal anatomy. Always use pigtail to position a stiff wire. Now let's say if you put a stiff wire and patient develop hypotension, what is the reason? It is severe MR. Majority of times it is tenting on a submitral apparatus. You do an echo, you would find severe MR and you pull out your stiff wire. Coronary occlusion, lot has been discussed. But if you anticipate the coronary occlusion, you use a coronary protection with a stent. Here you can see a SAPIEN 3 with a coronary protection using a stent, and a stent was deployed to displace the leaflet down. Can we do this coronary protection for valve-in-valve cases? Dr. Amit had already highlighted. Here is a patient who had a bioprosthetic valve failure, and we do basilica procedure, which is basically an electrosurgery where we will split the leaflet with cerebral protection. Here you can see sentinel device traversing the valve through a electrified stator wire, snaring the wire, and you can see a basilica is being done. The leaflet on towards the left coronary artery is split, and then we put a valve inside the bioprosthetic valve. And this is the final result. You can see the left coronary artery is flowing, and you can see how the leaflet comes right in front of the left main, and still the blood is flowing to the left coronary artery. What if your patient develops a cardiac arrest? Do you leave the patient? No, you continue CPR, do a BAV. That's very important. Now, if you have to minimize all these things, you need to know what you have to do if your patient is crashing. Don't leave the patient, put the valve first. Unsuccessful wire crossing. We already discussed there was a challenging case. Here's a patient where we could not cross antegradally, so we do a septal puncture and then snared the wire from the LV and did the TAVI at the end. Valve not crossing from this side. The reason is sometimes in this bicuspid valve there's a flap which comes across on the top of the orifice, and the valve does not crosses, so we would use a snare up front in these patients. And what does snare do? While we are crossing, the snare will pull the valve on top of its orifice and the valve can be deployed. The again self-expandable valve, the valve not crossing, what does snare do? You pull the snare medially so the valve comes on top of the orifice and the valve crosses. Sometimes we are pushing too much, the valve takes a lot of support of the outer curve, and these patients can have ascending aorta dissection. So when you are crossing the valve and patient complains of chest pain, it is time to stop. Just another 1 minute. In bicuspid valve, now we have to understand, we have to select the right size. So here is a circle method. Draw the circle of a certain size of the valve which is required and understand the interaction of the circle. And then we would also do a balloon sizing in certain bicuspid valves to understand. So here's a CT scan anatomy where a patient falls for a 26 and 29. We put a 26 which is -2 millimeter size, and this is how the result looks like. A 26 millimeter Edwards SAPIEN 3 is being positioned at the final position. So in bicuspids, we have to select the right size, and the circle method is actually helps us to understand what size of valve is required. Perforations, look at this case, 26 millimeter SAPIEN 3 deployed, hypotension, massive pericardial effusion. What next? What's happening? Any guesses? So you see a massive, you see annulus rupture there. The dye goes into the pericardium. What do you do next? You ask your colleague to do a pericardiocentesis, prepare your cardiac surgery, ask the patient to move to the cardiac OT. But in the meantime, what we did is we put in a guiding catheter, put an XP-LED30, filter wire, put microcatheter, and this is the final result. The annulus rupture was sealed with a coil. We also published this in Journal of Invasive Cardiology, percutaneous coil therapy for management of annulus rupture. So last cases, this is our experience of first 200 cases, MyValve Evolute Sapien. Our average age of cohort is 72 years. The standard STS score, the outcome is similar in all 3 valves. The procedure volume and outcome will also increase as the volume of the center increases. This is published in NEGM as well. Plan, anticipate, and prepare for the bailout. Thank you very much for the kind attention. And now course of that first sheet. Anybody wants to describe now? So that was a, yeah, because it was inserted on a soft wire, it has gone from common femoral artery, external iliac artery into the peritoneum.
It went outside the vessel.
Yeah, because the wire was removed. So what do? You don't pull the sheath out. We closed it with a fluency by taking additional access. So maybe I'll go back to that first slide. I'll play just for the, let me just play this slide again. Okay, here's the slide. And you see there's another axis which has been taken below the sheath. You pass past a wire. So don't remove the sheath. You put a fluency stent through the new 9 French sheath axis which was taken below this. Yeah, so always advance a stiff sheath, a bigger sheath on a stiff wire under fluoro.
Great, I think wonderful cases and wonderful teaching. I think so many things important things which if you miss, you can, take the patient to a wrong path. So, any comments from panel?
So, 2 questions only. So, wonderful presentation. How do you predict requirement of a pacemaker, permanent pacemaker, and how do you predict coronary obstruction?
So, I'll answer the first question. Patient who has right bundle branch block, number 1. Patient who has got trifascicular AV block, number 2. Number 3, patients who have short height membranous septum, lot of calcification below the RCC, NCC part of the annulus, and the percentage of oversizing. Lot of factors come into play when which would tell you that this patient is at high risk for pacemaker. But to begin with, anybody with right bundle branch block or a trifascicular AV block or first degree with LBB is at a high chance of requiring a pacemaker. Second, procedural is a deep implantation is a high chance of pacemaker. Second, coronary occlusion. Coronary occlusion is an interaction between the leaflet, the sinus of valsalva diameter, and the coronary height. It is not the TAVI valve which causes coronary obstruction. The coronary obstruction is done by the native leaflet which is displaced by the TAVI valve. So sinus of valsalva diameter, coronary height, and leaflet length. These are the 3 factors which will help you to predict whether a coronary occlusion will happen or not.
How do you assess this membranous septum?
So you do a CT scan, you measure the length of membranous septum. If it is more than 5 millimeter, you are fine. Less than 2 to 3 millimeter, high chance of coronary occlusion, high chance of requirement of a pacemaker. But it just helps you to tell that you don't deploy them too high. It just predicts that these patients are at high chance of pacemaker.
Dr. Subro has a question.
It's a fantastic presentation, Ravindra, as always. I think there are a couple of very salient points you have highlighted. I just want to reiterate. When we do coronary interventions, we assess the lesions, we decide the stent size, we do it, we do the IVAS, we optimize it. But when we do the TAVRs, we do the CT and we give it to the company people, and the company people will tell 26 valve, and you come prepared to put a 26 valve. I think the most important aspect of Ravinder's talk is the assessment, because 80 to 90% of the procedure is done outside the cath lab. If the CT is done, you have to sit down in the initial stages with the company person. You go through the CT, you identify the aspects from the access to the aorta, to the cerebrals, to the annulus, and then you decide it. You don't just come prepared to put the valve on that day. I think once you start doing it in your practice, you will see all these complications coming down. Comments? Yes.
Yeah, most of the time I find that the CT scans, they do not report the length of the leaflet. So do you think it has to be routinely done, or only would you request it if there is maybe the low-lying coronary artery ostium?
So that's a very good question, sir. It's mainly important for bicuspid anatomy. When you're doing TAVI in bicuspid anatomy, there can be one of the leaflets which can be eccentrically long and can cause coronary occlusion. Tricuspids, if your coronary artery is more than 12 mm, it's not required. But I think it's a good idea to measure the leaflet length if everything is borderline. let's say a 10 mm coronary height, narrow sinuses, narrow STJ, and bicuspid valve. So you can do those measurements in specific situations, but not all.
Thank you, Dr. Ravindra.
Thank you so much.
And now, may I request Dr. Suvaran Rai? We have been talking about lifetime management of aortic stenosis patient, and here we are. We will learn from Dr. Suvaran Rai when to go for TAVR and how to plan the lifetime management.
Good afternoon, gentlemen. My talk is, I think, the lifetime management of aortic stenosis. We have so far learned how TAVR has been done. It is a technical discussion so far. And, for any case, which is a revolution, when it starts, our first job is to do a safe procedure first. Then we plan what would be the events, what would be the future events, and the next 5-10 years. So far we know that the first TAVR was done in 16th April by Dr. Alan Crevier. And after that, what happened? After that, it is a revolution, it started. And you see, that in the next 20 years, down the line, we have moved from very severe, high-risk cases to low-risk cases. And also, we have come across a lot of evolution of the device, as for example, the self-expanding devices, balloon-expanding devices. And we have so far learned how these devices are handled, how to do a safe procedure. And also this slide, all these slides may be overlapping because we have already talked about it for 2-3 hours. And these are the low-risk cases. We know that from the risk profile, very high risk, we have come to low risk, and there is no difference between the outcome. Now, what next? The question is, what is the summary? The summary is, the next important thing is age. When to do TAVR? This is the most important question. And so far the guidelines are unanimous in one thing. Mechanical or ROS procedures maybe for the younger generation, mechanicals for up to 50. There is a cutoff, there is a gray zone till 70 years of age, after which there is TAVR or bioprosthetic valves. But what next? Between the two, in the gray zone, what should be the best option? So there comes the importance of durability and the future events perception of the device. So low-risk patients, the recent data showed that there is no difference between the patients randomized to TAVR and SAVR. So TAVR can be used in low risk, high risk, but can TAVR be used in young generation? That is the question. So within these 20 years, we have seen that SAVR is coming down in the proper age group, and TAVR procedures are increasing. So, and also, though there is a difference between the SAVR and TAVR according to the durability, it is found, though TAVR is less durable than SAVR, in the younger age group, excepting in the younger age group, other age groups above 75, they are same. So we can use TAVR above 75, above 70, and that age group it has been complete. But what in the younger age group? Again, I am coming to that. So what are the problems if we use TAVR in the younger age group? There are certain points which are being highlighted by my previous speakers. All of them are being highlighted. So I am just recapitulating. One is a patient prosthetic mismatch. If there is a patient prosthetic mismatch, the durability of the valve and the complications will be more, and you have to have a shorter duration of the valve functioning. Paravalvular leak, coronary reaccess. Already we have learned so much of coronary access and all, and the permanent pacemaker. These four or five are the most important factors which determine that whether TAVR should be used as a primary therapy in the younger generation. And as because this valve is a inactive, non-living tissue, non-vital tissue, and there is lack of endothelium, so there will be always a wear and tear. And also the valve, some valves are being prepared by glutaraldehyde. These are not like a normal functioning vital valve. So the valves can attract calcification, and particularly at the commissural points, and this calcification and mineralization and some non-mineralizing factors that will cause the less durability of these valves in TAVR patients. And how we know that these TAVR procedures are going wrong, there is a WARC 3 definition through which we can know that whether it is going down, the valve is not functioning well. And there are some clinical presentations which will show that there is bioprosthetic failure and some stage of deterioration. In the stage 1, there is, in the stage 1, which may be not apparent rightly. After that, when there is an increase in transvalvular gradient more than 10, or there are certain criteria, this can show that there is a failure of the bioprosthetic valve. And if the gradient is more than 20 or there is a severe AR, then you know that your valve is gone. Then you have to do something for that. And this is also, we have learned so far that the procedural and patient-related risk factors also play a part for the TAVR procedure. As for example, if you can align the valve with the commissures, there is a less chance of PVL and less chance of coronary problems and less chance of wear and tear, so that the durability is increased. We have known that. And perhaps the newer generation valves, like Accurate Neo, it is easier to align them along with the commissures, and they will help it better. Patient prosthetic mismatch, we have also learned that it should be, already Amit has said that it should be used supravalvular deployment, and probably the self-expanding would be better than the balloon expandable. But again, we need something to be done in this front so that the patient prosthetic mismatch is less, and along with the other problems with the self-expanding valves which can happen should be reduced. Again, the obstacles of coronary access, we have also learned that there are 3 important factors, and one of them is the height of the skirt. Number 2, the sinotubular junction dimensions, the sinus of Valsalva dimensions, as well as the leaflet heights and coronary heights. These are the important factors which can affect the coronary access later on, because if I implant a valve in the young people, there would be always a chance of coronary involvement, and which would be difficult if that is not been done properly. Next is the conduction system disturbances. And again, we have so far discussed about the conduction system disturbances, but it is found that using a pacemaker, the life expectancy is less. It is already found that even a new onset LBB is not benign. It can have a sudden cardiac death. It increased mortality, and only pacing dependency in 40% is associated with the higher risk of heart failure and mortality. So we have to have a device, and it is found that TAVR has got more amount of pacemaker implantation than any SAVR or anything. So we have to reduce the pacemaker need, and their works have been done so far. So again, the valve placement and the valve types, like it is found that is more with self-acting expanding valves, where the Medtronic valves are used mostly, but with the Accurate Neo and its placement, correct placement with alignment of the calves, commissures, the pacemaker implantation may be reduced, and it is seen that pacemaker implantation is getting reduced with the newer types of valves, and it is in 1 digit now. Sorry. So, what will be the possible advantage, and how we go? So, again, we have discussed valve in valve right now. Then we have seen that with SAVR, it is the second procedure. If I plan with a SAVR, the second procedure, if it is TAVR, it is fine, no problem so far. But if it is a TAVR and the second procedure is a TAVR, it is a difficult proposition altogether. And we need to develop certain things like basilica, like chimney. So we have to have more works in that field. So if I use a TAVR in a young patient, we need to do something to reduce a lot of complications which can happen. And the third procedure is, beyond imagination. So what we can do? So if I, at this point, till is in 2023, we have certain things. And in very young people, I think the pulmonary autograft or Ross procedure would have been the choice because it's a normal valve and the valve will grow along with the patient. And between 50, the best would be mechanical. And after that, SAVR in the subgroup. And beyond 80 and beyond 75 maybe, TAVR would be the a procedure of choice. So the key takeaways is TAVR is a solution to all risk categories. There is no doubt. It can act both in high risk and low risk in severe AS. The most important factor is the age, and as the durability of the valve is in question in the long run. So if I have a life expectancy more than 10 years, I have to think that whether I should go for a TAVR or something. If it is more than 15 years, I should not probably put a TAVR in 2023. Continuous improvement will enable us to use valve in very young people. Till date, we are hoping for that. Until then, it should be used in patients where the life expectancy is around 10 to 15 years. Thank you very much for patient hearing.
Excellent presentation, sir. I think why we are talking about lifetime management of this aortic stenosis patient, because I think we have to be really understand surgery is still not out of question for these patients. Important thing, if at all, if the patient is having a surgical option, it should be the first procedure will be the surgical procedure, because the explant TAVR, if you subject this patient to TAVR first, then the second, if any problem happens, if the valve degenerates or any issue happens, then the second procedure, if you think you cannot offer anything to this patient, then the surgery will be very difficult. The explant TAVR registry has showed to explant this TAVR valve, the mortality rates, 30-day mortality rate is as high as 20 to 25%. So every young patient doesn't mean they are low risk, all the patients are low risk. You have to understand the anatomics, you have to understand the life expectancy, you have to plan the future also, because the TAVR valve as of today are having a durability of 9 to 10 years. These patients are going to come back to us again for a second procedure. So whenever you are treating the aortic stenosis patient, you should always think of what are the options we are leaving for this patient for the second procedure. If you don't leave any options for them, they are landing in a nowhere zones. I think you want to have any comment?
Talk, and we end the session here. We'll move on with the next session.
Thank you so much to the chairpersons. Thank you all the speakers. Thank you so much. We close the session here. Moving forward to the fourth session, I would like to invite the coordinator of the session, Dr. Muthu Kumar, chairpersons of this particular session, Dr. Bishokesh Mojumdar, Dr. Shankar Mondol, Dr. Ranjan Kumar Sharma, Dr. Satyajit Shamanto. Discussants of this particular session, Dr. Shubhro Banerjee, Dr. Rituparna Barua, Dr. Smith Srivatava, and Dr. Umesh Kohli. Requesting all the chairpersons.
Dr. Nil Dhal sir to chair the session.
Thank you so much.
So we have Dr. Kapadia's lecture now. We have two lectures in this session. Dr. Anuj, are you there? Dr. Anuj Kapadia. So we can, if not, then Dr. Anuj, yeah. So we have 2 lectures in this session, Dr. Anuj, and then there will be a lecture on TMVR by Dr. Viveka Kumar.
Thank you, sir, for this opportunity, and I'll keep it short. I think everybody is hungry as well. So calcium, I think, is friend and a foe in TAVR. Friend in terms of it helping in anchoring the device, and foe in terms of delivering the device and all the complications associated with it. I'll start off with a case vignette. This is a 74-year-old lady, hypertensive, diabetic, post bypass in 2009, came with dyspnea on exertion. He had this baseline LBVB with a first-degree AV block, diagnosed to have severe aortic stenosis and with patent grafts. So this is her echo, a mean gradient of almost 50, has significant MAC as well, but no mitral stenosis as such, and a good LV function. So if you look at this CT, I've just taken some excerpts out of it. You can see annular calcium, nodules of calcium in the nodule, calcium everywhere actually in the sinus of Valsalva, in the STJ, and also extending into the LVOT. And this is a CT TAVR protocol. So you see significant amount of ascending aortic calcium as well as valvular calcium. The heights of the coronaries actually didn't make any sense because the it has patent grafts to right and the left. You can see here in the middle, you can see a lot of calcium extending into the LVOT here, chunk of calcium extending into the LVOT. And this is the overall picture, ascending aortic calcium, coronary STJ calcium, calcium at the annulus extending into the LVOT. So you have calcium everywhere. You can see the same calcium over here as well. So this is the CT. If you look at it, as you scroll down, you can see that as you scroll down on the Tremensio, you can see the significant amount of calcium there. Now, what are the procedural considerations that we have? This lady has a post-CABG, has calcium in the annulus extending into the LVOT, calcium at the STJ, so STJ. This would have been an issue if she was not post-CABG because coronary occlusion with STJ is a significant issue. Calcium in the aortic arch, calcified iliacs as well, I didn't take those excerpts, and mitral annular calcium. So basically there's calcium everywhere. So TAVR and LVOT calcium, issues related to LVOT calcium. I think 40% of patients have LVOT calcium. Moderate to severe, which is actually rules the result, is around 25%. There is increased risk of annular rupture, more with balloon expandable. I'll come to the details. More if there is oversizing, more when there is left LCC calcification and myocardial free wall calcification. Increased risk of residual AR or PVL, increased risk of a second valve because AR related, increased risk of mortality, and increased risk of PPI as well. Now, the multiple trials that have gone into this, the trials that have actually seen the impact of LVOT calcium on procedural outcomes, the multiple trials in different journals that have been done with balloon expandable as well as self-expandable, they've come to a basic criteria that they've put in where they see the nodularity, the dimensions of the nodule and the percentage perimeter of the LVOT which actually has calcium. So if there is mild LVOT calcification, there's only one nodule which is less than 5 millimeters in dimension and is occupying less than 10% of the perimeter, it's mild, and so on and so forth, where they have multiple nodules, significant amount of calcium, the size of the nodules, and is occupying more than 20% of the perimeter, that is for severe LVOT calcium. Now, risk of annular rupture, basically, if you look at this, you see that patients who have severe LVOT calcium are at higher risk of LVOT, higher risk of annular rupture. So basically, if you look at this, patients with LVOT calcium, three major issues are a bailout valve in valve, an annular rupture, and a coronary and a cardiac tamponade along with residual AR. So basically, because of the residual AR, they need a bailout valve in valve. Annular rupture and cardiac tamponade go hand in hand as well. So basically, you're dealing with a lot of complications that can happen. So we need to anticipate this before. And looking at all the meta-analysis, the balloon expandable actually fared much worse and caused more annular rupture. I think it's more so because the self-expandable is a more soft landing, it's more about conformation there, so it goes very comfortably and sits there, whereas balloon expandable is a more jerky expansion of the annulus, and where the stone sticks out, we don't know. So that probably is the reason. I think Ravindra Rao sir's lecture also, one of the balloon expandable, he showed the annular rupture. And there's an increased risk of residual AR. You have rocks everywhere. The valve doesn't conform where the rock is, and so that's where the opposition of the valve is not proper, from where most of the time there is leakage. And if you see that, see here, patients with moderate to severe have significant amount of moderate severe AR. Actually, not every PVL that we have, we should post-dilate. I think it's very important to define the reason for the PVL. It's important to do a transesophageal echo for patients with significant PVL. If there is a significant amount of calcium from where the leakage is happening, how much ever you dilate, the risk of annular rupture will increase, but your PVL won't come down. So those are cases where you may have to actually do a device closure later. Increased risk of mortality. Obviously, with all the complication rates that there are, the risk of mortality is much higher with patients with moderate to severe AR. And so basically, how do we prevent it? We assess the LVOT calcium severity. We need to read our CTs, as Dr. Anant was recently just saying. It's important to know how to read and have an insight before we go into the procedure. Use a self-expandable valve. Avoid oversizing by more than 10%. Conservative pre-dilatation. Avoid too much of valve manipulations. The chances of CVA is much higher, and avoid aggressive post-dilatation as well. So in our case, if you look at this, patient had multiple nodules, a dimension of more than 10 millimeters, and a perimeter of more than 20 being occupied by the calcium. So basically, she came into the severe category. So we thought we'll predilate with a 14 millimeter balloon, undersize the predilation just for the valve to go in. It was a 26 millimeter valve based on the dimensions, and the percentage of oversizing was only 18%, so we were within the 20% bracket. The patient had a baseline LBV with a prolonged PR, so we did already counsel them for a PPI, which was inevitable. It was a tubular outflow, so we thought we'll accept a little lower position also, because PPI was anyway inevitable, and avoid too much of manipulation. So this is what it was. A good injection in the NCC. You can see the amount of calcium there is, MAC, the LVOT calcium that is extending into the calcium that's extending into the LVOT. We pre-dilated with a 14 and deployed it a little low itself. We started deploying in the cuspal overlay. This was the, there's a little low. There's no PVL. We got good gradients. The AI index also was not good. So we thought we'll hang on there. Post-procedure, within 48 hours, we put in the pacemaker, discharged the patient in 3 days, came back asymptomatic after 4 months with a single-digit gradient and good LV function. The pH also had come down. So I think, just to conclude, ladies and gentlemen, LVOT calcium increases the risk of adverse outcomes. Heart team discussion and knowing our CT scan is extremely important in deciding between TAVR and SAVR. Self-expanding valve is preferable to avoid annular rupture, and it's better to avoid aggressive pre and post dilatation, avoid oversizing of the valve, and be ready to tackle the complications like including annular rupture. I think here it's important to know that perfection is the enemy of good. It's better to accept a little bit of PVL and not be too aggressive on certain things. Thank you.
So the calcium load, location, extension, they're all important. Do you think the mechanisms are a little different for nodular calcium or extensive calcium? Because you had extensive mitral annular calcification also in this case.
Yes.
So do you think that there are different mechanisms when you're dealing with nodular calcium? Because as I understand, nodular calcium may increase the risk of AR, may increase the risk of, so PVL. So therefore, Do you think there are different mechanisms at play?
Yeah, actually, it's like they are like stones over there, very irregular stones. So nothing actually expands beyond a point. And those spicules, where they are, when you're expanding or you post dilate, what will tear, we don't know. So it's always better to be a little gentle on them. And that's why the self-expandable is better in terms of it landing.
So in this case, you prefer to do a lower deployment, a deeper deployment. No, you had already decided that the patient is going to need a pacemaker.
Yeah, because already there is an LBBB with a first degree AV block.
Which is a fair decision.
Yeah, so we didn't actually want to go in and out, recapture and all that, because the chance of embolization and all those things will be a little higher. So we thought we'll be a little conservative on that.
Just a quick question. Sorry.
Sir, I would like to ask one question. Sir, in case of PVL, in certain scenarios, calcified LVOT and annular calcification, would you like to post-dilate with a semi-compliant balloon as ZMAID or a non-compliant balloon like BARD? And what will be the balloon size according to the waist in semi-compliant and non-compliant?
See, semi-compliant, basically you go to the, you size equally to the annulus. Whereas a non-compliant, you go -1. This is what we normally do. But with so much of calcium, I would probably be a little conservative, be -2 to dilate, because I don't want an annular rupture. I'm okay having a little PVL which I can close later with the device, or see how it goes over a period of time. Sometimes a self-expandable, after 48 hours, you actually do an echo and you see that the PVL is actually gone. So I would probably be a little conservative on that.
But nodular calcium may more likely give you a PVL rather than an annular rupture, whereas a diffuse calcium is more likely because you're using higher pressure, so you're
correct.
And a question about the nodular calcium. All nodular calciums may not be the same. Some may be a bit more cheesy, some may be really hard. Is there any way to predict it? And I mean, is there anything you can do if there is a large chunk of nodular calcium? Is there anything you can do?
Basically on CT, if you see the calcium score of more than 6,000, we are sure that you are going to end up with a little bit of PVL for sure. But generally, between 3,000 and 6,000, still it's based on a particular nodule which may not give you so much of numbers as well. But sometimes when it's more than 6,000, you can definitely tell the patient that, okay, you are going to have a little residual PVL, and because of the amount of calcium that you have.
Yeah. Wonderful presentation. I think it also depends where is the calcium, so now outer curvature or inner curvature. So the calcium on outer curvature, chunky calcium pointed towards the LVOT and annular, annulus, it's going to cause a lot of problems.
Yeah.
And yeah.
Thank you. Yeah.
Great. So we move on. We have.
Yeah, Anuj, one more point. How does this extension of calcium, whether it is a non-coronary cusp, right or left? So since we have seen in many studies that non-coronary calcium is more causing annular ruptures. So what could be the reason for that?
So basically, it's a more freer area from where it can actually leak. That's one thing. And the second thing is, depending on the calcium, is also where your pacemaker rate is also going to be. Because if there is a calcium on the membranous septum, you are already having there is a degeneration of the node there. So automatically the chances of PPA also is higher based on the amount of calcium distribution.
So thank you very much. I mean, calcium is scary. But I guess fortune favors the brave. So we have another brave operator, Vivek. Now you're going to take us through a TMVR case. Thank you, Anuj.
Well, so I think I'm standing between all of you and the lunch, so I'll keep it short. So I think as throughout the discussion has been shown that, more and more patients who have had surgical valve implanted, they would be needing, valve in valve. And then in mitral space, as of now, we do not have in native valve putting a new, transcatheter valve. It's not matured as much as the tower is. So if you see the untreated mitral regurgitation or mitral stenosis, so mitral stenosis, fortunately, we deal with the balloon mitral valvotomy with great success, but for the replacement of the valve is a difficult proposition. We have got now access to, mitral clip, and we're doing on a regular basis to counter that. But there is a space where, in patients who already had a mitral valve replacement with the tissue valve, if they have got a degeneration of the tissue valve, then we have to, replace that valve. And we know that the redo surgery would be a difficult ask in them. So in de novo, there are multiple options coming in patients with intrepid valve and all, but definitely all of them are still not, used on a regular basis. But for the valve-in-valve, we have got the existing balloon expandable valve is the answer in that. So either we can have the Sapien 3 or we can use my valve, but the challenges has to be defeated. So in unresolved challenges, one of the problem can be there, when we do the valve-in-valve in mitral space, LVOT obstruction with the hemodynamic compromise can be there. The anterior leaflet displacement or ventricular aspect of the valve stent outflow obstruction could be there, and development towards completely percutaneous approach via transfemoral venous approach, septal access with a smaller device profile will help to address more of these issues. So we need to look at the, whether there is a paravalvular leak, because it is valve-in-valve, so the risk of stroke may be higher, coronary compression, and sometimes the mitral infarction can also be there. And of course, the tamponade is always in these kind of situation problem, which we have to always look for. So unmet needs is there in patients who already have had a tissue valve, and then TMVR is the answer in them, valve-in-valve. So severe mitral valve disease due to the degenerated bioprosthesis or failed surgical repair with annuloplasty rings are there. So there are a lot of cases where we are doing for the ring also valve-in-valve. In that space. The native mitral valve disease with severe mitral annular calcification who are not eligible for conventional surgery, like in last case where the TAVR was done, there in future that patient might need the, for mitral annular calcification may need balloon expandable valve. So there are specific challenges with the TMVR as against TAVR. It has got more complex anatomy. There are a lot of patients who have got rheumatic disease, atrial fibrillation, and the other concomitant valve disease are more common. And there is a, so because of the unpredictability of the structure in that space, there are a lot of challenges, and that is why the de novo valve we cannot do. So if you see the steps for TMVR, we have to have a right patient selection. So we have imaging is very important, and the previous valve size is very important, because we go from Baput's algorithm by which we choose the size of the new valve. Vascular access, again, it's transvenous there, then we need to be doing a transeptal puncture in the appropriate place, and then valve deployment, and then the closer to complete the thing. So transesophageal guided, all the TMVRs we have to do is transesophageal guided to identify the mechanism of the prosthetic failure. We need to, if the septum have to be identified, how thick the septum, as you can see here, we need to find out where to puncture this. And then it also uses to increase the safety and success rate in patients with thickened or hypertrophic atrial septum, because sometimes we need to do a septal puncture with the radiofrequency ablation. So the transeptal puncture is key for the good success. So we need to have a proper view, like T in bicaval view, and then we need to locate where the appropriate place is. Fossa vallis, we need to do slightly posterior puncture, and then we have to, the good thing is that, after the puncture we can give the heparinization and all. The Agilis sheath is key to the success, because with the deflectable sheath we can, steer the catheter towards the LV inflow and the apex, and then standard J wire is passed towards the LV, and then we took a pigtail just to make sure that we have not gone through the chordae, and the temporary pacing is inserted into the right ventricle to pace when we are deploying the valve. So I'll be showing a couple of cases also. So it is something where the support wire has to be placed through that, go into the LV through that valve. We dilate the atrial septum also with the 14 French over the stiff wire, and also we take it into the flossing of the valve. So older valve we need to see whether the balloon is going there or not. And interatrial septum, again, one has to dilate. We usually, unless in valve, we try not to do a pre-dilatation if it is leaking valve, so you know that there is enough space. But if it's a stenotic valve, then we do a pre-dilatation as well. And then we, take the valve and do the adequate positioning. So the valve deployment is mainly, under transesophageal guidance. We remove the parallax and then take the valve and then, do the procedure. And after that, we need to remove everything and do what we call figure of 8 close of the venous access, or we can do, per closer also. So the first case was a 83-year-old lady who had significant symptoms, had resting mean gradient of 21 millimeters of mercury, and she was mother of one of our surgical colleague also. She had a 27 millimeter size perimount bioprosthetic valve was implanted almost 15 years back. Ejection fraction was normal. So this is what we do, the CT, to look at the measurements also. And aortomitral angle is something which has to be looked carefully in this situation to avoid any LVOT obstruction. And we need to also look at the neo-LVOT outflow tract so that we know that the LVOT obstruction is not happening. So this is a, the transesophageal 3D reconstruction of the mitral valve. You can see the gradients are very significant. So this is what I was discussing, that under transesophageal echo guidance, we have crossed into the left atrium, and then through the, with the help of the deflectable, Agilis sheath, you can direct your wire into the LV through the prosthetic valve, and then put a safari wire there, or extra support. And then we do with the 16 into 40 millimeters balloon, with the mammoth balloon, we dilated the septum, and we also dilated, because it was a severely stenotic prosthesis, so we dilated the prosthetic mitral valve as well. And after that, you can see this is the flossing where we made sure that the valve can go, the new valve can go through this. So after this, you could see that the valve passage is quite easy, and you need to be careful that your partial deployment has to be there, and then you have to center it so that it does not pop in and out of the valve. So you need to be very, very slow. So this is one procedure where the inflation has to be really slow, and then after removing the parallax, you see everything. Once all the parameters are okay, then you can take it out, and the patient was home in a couple of days. So this is the post-valve implantation echocardiography, and you can clearly see the gradients has come down significantly. Another case was a 76-year-old lady who has multiple episodes of medical intervention. First of all, she had a bioprosthetic valve, 25 perimount, and then she had went into atrial fibrillation, had a saddle embolized after 3-4 years of that, and then had vascular surgery to remove the that, and then she went into, had 6 sinus syndrome, so she had a pacemaker implantation, and this time she came with repeated hospitalization due to the heart failure. Her ejection fraction had also dropped to 35%, very symptomatic. So again, we needed to do a CT to find out the same parameters in this. And then the most important thing is that you have to have the information about the previous valve. So these are the measurements which we do just to see but the major decision is always with the algorithm of valve in valve, that Baput's algorithm, which is very, very handy. So we need to focus on the aortomitral angle as well. And so this is the multi-slice CT measurements are there. So in this case also, we went there. So you can see she was a post open heart surgery, post pacemaker patient, and had failed, mitral prosthesis. So she had, raised drop also. So we did the angiogram. You can see the distal disease was there. So again, it was a, transesophageal guided puncture. You can see the same steps were taken with the Agilis sheath. We could cross to the, mitral valve prosthesis. And then again, we did a pre-dilatation of the valve and as well as the septum. And after that, we took over the safari wire, we could took this is the patient, the new valve, and after, on rapid atrial pacing, the valve was deployed and the parameters were looked at and everything was good. In last case also, this patient also had similar, had a post mitral valve replacement, and then had again sudden cardiac arrest, out of hospital, documented recurrent VT, normal coronaries. So then had implanted an ICD, and the similar steps in this case we used the SAPIEN 3 valve. So same steps were done. In the interest of time, I'll just run through the slides. So TMVAR is a concept where valve with valve is the established indication, but now the future would be that we have got for the de novo valve also. We know that the mitracloprenol is there for leaking valve, but for the de novo valve we are still far from what the current technology in tower direction has matured. So thank you very much for your kind attention, and if there is any question, I'll be more than happy to answer that.
That is super fast, as usual. I mean, my understanding is that you need to have very good support from your echocardiographer when performing a valve-in-valve or TMVR, and your images were largely fluoroscopic. So I think, would you like to tell everybody as to how, firstly on CT, did you calculate the neo-LVOT, and did you predict whether what would be the possible challenges? Secondly, when you were performing even the septal puncture, what did you ask? I mean, it's okay to say posterior inferior, but whether you have a smooth transition from the septal puncture to the mitral valve, and then how? Just let us know briefly.
Yeah, so I think it is very important that you need to have the understanding of everything, but as you for this space, saying that we have done thousands of balloon mitral valvotomy, it will be cakewalk for us doing a TMVR. It's not true, because you need to be really, because these are the things where you need to be experienced with the gadgets of tower. So people who have done tower, for them the handling this device is easier. So you need to have a planning before, as Anand was saying, that the more planning is something where 90% of the thing is in the planning, and then 10% you can execute. So it is like you become a robot. Whatever information is given to you, you calculate everything and then go and execute. So if you have got, so that is why I feel that in a structural space, there are a lot of things which AI would help us in future also, because as the imaging is becoming more and more precise, this gives you all the information that you need to just, you can put an X mark that this is the place in the septum you need to puncture it. This is the height from the septum, from the mitral valve, so that is the place where from the entry will be easy. You have a deflectable, catheter, Agilis sheath, through which your entry will be easy. But you need to be understanding all the complication also, that, have you gone through the, when you have put the wire, have you gone through the chordae, whether you will be rupturing the chordae and creating a, problem there. So all these things has to be.
So do you do a standard puncture? Do you use some RF catheter for the puncture? Do you attach an electrocautery to a CTO wire or something? How do you puncture the septum?
No, so in most of the cases, I think the standard puncture. So I always tell that, you need to keep things simple. And when it goes, it doesn't help you, then obviously you need to go to next step. So I think if the problem in the first puncture is there, you feel that the septum is really, really thick, which can happen in post-operative cases, then obviously you can take the RF, and so that facility should be there. But obviously it's not that it has failed. There are many cases where, I've seen people presenting that they did not have the RF facility, and then they postponed the case and then brought the case again for the next.
So what residual gradients do you accept?
So I think it should be obviously less than what you began with. So it should be around. So we say that it should be less than 6 mean gradient should be good enough.
Yeah.
And
I have one important observation. We have done one case. Dr. Banerjee will present. It was his case TMVR with TAVI. But the cases which we have seen, it's quite difficult sometimes to negotiate the septum with the valve. And one of the presentation in CSI conference in Frankfurt, the operator couldn't negotiate the valve from the through the septum. So this septal preparation is very important. You need to go with a good size balloon and then dilate it and move around the balloon in inflated stage. It's very, very important step.
Yeah, so that's important. I think Ravinder is sitting here. In one case, the valve was just not going through the septum. We have dilated with 16 also, so we took a buddy wire. So we took another wire to, placed into the LV, and through that support it could easily go. In another case, the valve was hitting the frame. So again, in that case, we took a body wire and it did go. So I think location of puncture is very important, but as you would know that anatomy may not be the standard one because of the disease process. LA may be dilated or your puncture, sometimes puncture is important where you have not punctured may not be, because success of puncture is also very important. So I think these are the few things where you need to be mindful that if it doesn't work, then what?
So and when do you close the atrial septal defect, or do you leave it, or what are your considerations?
No, so I think in most of the cases, even this LV dysfunction case and all, we have never closed atrial septal puncture site, and they do well. So now the recommendation is that you don't really need to close it.
Okay, I think Dilip is telling us, and everybody is hungry. So thank you for a very masterly presentation and quick presentation. And we close the session, and Dilip invites everybody to lunch.
Right. Thank you.
Thank you.
Thank you so much. So we'll break for lunch. And we will be reassembling again for the next session post lunch at 2:25. Enjoy your lunch, everybody. Thank you.